Yeah, thank you very much. Yeah, my name is Dr. George Moses Ogweno. I'm a gynecologist and a fertility specialist, also working at the Nairobi Hospital and in private as well. So we are going to So thank you very much for coming once again. So we have a very big team from gyne-oncologists. I'm sure we also have quite a number of people who have joined virtually. You are most welcome as well. Thank you very much. I'm going to introduce our chair, division of Obs Gyne, MSc chair, who is going to chair the first session with Dr. Paul Koigi. I think he's somewhere on the way, he told me. Yeah, he's coming. And we'll introduce our speakers and we start the first session. So welcome Dr. Carol Odula, chair of MSc Obs Gyne, Nairobi Hospital. Thank you.
Thank you, Dr. Gweno. For the record, I am not the chair of the MSc. I chair the Division of Obstetrics and Gynecology. So just some brief remarks. You are all very, very welcome. The team welcoming you are somewhere there in the back, but I'll take the honor of welcoming all of you to the Nairobi Hospital. So a bit of fun facts about Nairobi Hospital. Nairobi Hospital was conceived in 1952, October 20th, and delivered normally 2 years later. Some fun facts which I'm sure many of you did not know. So how old is the nursing school? If anyone can just volunteer and tell us. Those are one of our landmark, you know, what Nairobi also does. How old is the McDonald nursing school? Nobody knows. Yes, excellent, excellent, excellent. And who was the first African practicing physician at the Nairobi Hospital? Guess. He removed a wisdom tooth, Dr. Chris Obura. And that was in 1961. He was the first African practicing at the Nairobi Hospital. The North Wing has been with us since 1974. And at this moment, we have over 700 admitting staff. And we keep admitting the new ones as the older ones mentor us young ones. So 2016, the nursing home was fully fledged and upgraded into the College of Health Services, 2016. And when was our COVID treatment facility launched? Which year? Rough guess. COVID hospital through UN? 2020. 2020. And, you know, Nairobi Hospital is a hospital of firsts, and we celebrate that fact. The fact that we're here together as we commemorate the Reproductive Health Symposium every year. This is our 17th year. We have not missed a single year. Even during COVID, we did it virtually over a few months in the evenings, and that succeeded. Today, I'm particularly honored to welcome our team of gyne-oncologists. And without further ado, our first speaker is Dr. Maranga. Where is the bio? Where's bio? Is your bio here? Let's make it down. Okay, so Dr. Aurora Maranga is an obstetrician and gynecologist, and his CV is very long. He has an MPH from the UK, permanent head damage. Oh, sorry. A PhD in gynecology from the UK. He's a fellow gynecology from the University of Nairobi, and also he's a fellow of in the EXA region of the College of Obstetrics and Gynecology. He is a consultant oncologist from KNH and an honorary lecturer from the University of Nairobi. Dr. Aurora Maranga, karibu sana.
Thank you, Dr. Caroline Nodula, for that welcome and for that introduction, very kind introduction. Good morning, everybody. We're going straight to the first of these presentations, which is the state of gynecologic cancers in this country. So we also welcome those ones who are on board. Since we are talking about action, this year and this symposium is about action. So I would like to share with you some images about what has been happening on the ground in terms of building up capacity, professional capacity for gynecological cancer treatment. And there we were privileged to have Professor Mondi Ogutu. Of course, all of us know him. He was the chair at the University of Nairobi when the first gynecological oncology fellowship was launched in Nairobi. Of course, University of Moi or Moi University had launched earlier, and we have Dr. Eli Odongo here, Professor Menge, and several others who are our predecessors. So this is the first class, basically, there with Professor SBO Ojuang during the graduation. That is Professor Juang there with the team, with the first batch of gyne-oncologists. I'm sure you're seeing familiar names there. Part of the action, of course, is the surgeries which are done by this particular team. And I must also acknowledge, of course, that this is just University of Nairobi. Moi University has a very vibrant program. There are others in this country, gynecological oncologists, who have trained in South Africa, who have trained outside this country also. So we also appreciate them. They're part of this presentation also. Part of really what is done by this particular team, Sister Mary Joseph's there, which is basically a metastatic tumor, which is just infraumbilical, and we had to do excision. An ovarian tumor there. And next, first to the basics about this particular country. We are talking about action for gynecological cancers for this in this particular country, in Kenya. Of course, we do know that we are at the moment up to around 54 million. The median age is 20. The population growth rate is 2.2. Birth rate is 27.2 births per 1,000 population. Death rate is 5.2. Life expectancy has actually gone up, and we're going to see it as part of the explanation why we are having more malignancies. At the moment, it's around 69 years. It's come all the way from independence when it was in the 40s. And the health expenditure, and this is important for us, is low. And we're going to see that also in terms of the budget for cancers in this country, it's also low. That's 4.8% of the GDP. The rest there, you can see the physicians, they're low in terms of the population. But impressively also is the mobile telephony. We have almost one phone, literally speaking, per person in this particular, in Kenya. And then we'll have to devise, I know Dr. Baraza will maybe talking about it in his lecture later on, about how to utilize this mobile telephony in terms of reaching out for gynecological awareness and also screening and messages. And of note is 40% of Kenyans are younger than 15 years, and the remaining majority are between 15 and 64 years, and less than 4% are actually older than age of 65. But as we are going to see later, almost this particular age, the 4%, actually bear almost 30% of the cancer burden in this country. So a bit on the cancer incidence in Kenya. On the left there, as you can see, is the incidence in both men and women, and in all ages. And in all ages, you can see the women tend to actually take the bulk of the burden, starting with breast cancer, 15%, cervical cancer, 13%. We have others like esophageal, prostate in men, colorectal, lymphoma, stomach, leukemias, and number 9 there, you have ovary. So in terms of gynecological cancers, and that is where these gynecological oncologists assist in terms of treatment, we have cervical cancer, which is there number 2 overall, and then we have ovarian cancer number 9 on the left, and then we have endometrial cancers or uterine cancers, vulval cancers, and we may not have enough time, but 60% of vulval patients in this country are HIV positive. Of course, you're talking about HIV, even cervical cancer, we have a very big population of HIV reactive patients coming out with cervical cancer. There's GTN and also vaginal. Of note, of course, is breast cancer. As much as in this country it is mainly handled by general surgeons or other specialties, gynecologists tend to be the first first stop for most of these patients, and we tend to diagnose a number of them and then refer accordingly. So we do know that cancer is the 3rd leading cause of death in this country after infections and also cardiovascular diseases. And cancer is the 2nd non-communicable disease after cardiovascular disease. So that's how important it is in terms of disease burden in Kenya. According to International Agency for Research in Cancer, 2018 report, it estimated that around 48,000, we had around 48,000 new cases of cancer annually, with a mortality of around 32%. And if you compare this with 2012, then you'll note that there has been around a 45% increase in incidence, and as compared to previous reports. And then there has been around 16% increase in terms of annual mortalities. Now the number of new cases, cancer cases, is expected to rise by more than 120% over the next 2 decades. We are going to see a representation of that shortly. So on this graph here, on the left we have the top 10 cancers by incidence in Kenya, which I had shown you earlier. And on the right, we are talking about the top 10 cancers by mortality in Kenya. Of note, of course, is if you compare the 2 graphs, on the left, the number 1 is breast in terms of incidence, but when you cross over to mortality, then cervical cancer overtakes breast cancer in terms of causation of deaths. This is the 2020 report. Of note, of course, is the liver, the pancreas. In terms of mortality, they now become top 10 as much as the top 10 incidents, they are not appearing. Now, what are the predicted trends in this country? On the left there, we can see the predicted trends in the incidence of new cancers in Kenya. That is in the next 20 years, that's 2 decades. And of note is by 2040, we will have like 126. We would have had incidents increasing by around 126%. And in terms of mortality, on the right graph there, we are going to have around 136% increment in terms of mortality from cancers in Kenya. So what are the reasons for the rising incidence? There is increase in life expectancy, adoption of unhealthy lifestyles, unhealthy dietary habits, consumption of tobacco and alcohol, lack of physical exercise, improvement in diagnostic capabilities for detecting cancers. You know, we also have like PET scan at Aga Khan and also at KU Hospital. And of course, we have MRIs and CT scans in most places. So the improved diagnostics has also brought out the actual figures in terms of the incidence of these diseases. The presence of HPV in terms of cervical cancer, anal cancers, penile cancers, and also HIV acquisition tend to explain why we are having a rising incidence. So we have already talked about the common cancers, and 60% of Kenyans affected by cancer are less than 70 years. And this is really the bulk of our patients, as much as we are saying that the fewer older people in our population, they tend to have an uneven number of cases of cancers, generally speaking. You've already talked about that bit, about 40% of Kenyans are aged above 70 years. I mean, in terms of cancer incidence, 40% are aged 70 years and above, and yet this segment accounts for less than 3% of the population. Now, the risk of developing cancer before the age of 75 is 18% among women and 14.3% among men. The risk of dying from cancer is 12.7% in females and 10.3% in men. We are talking about Kenya. According to the National Cancer Registry data of 2021-2022, Central Kenya and also Eastern regions have the highest number of cancer cases. And in terms of counties, Nairobi, Nakuru, and Kiambu counties take the lead. Now, 66% of people diagnosed with cancer will usually succumb to the disease. And 70% of cases are diagnosed in advanced stages. It's actually 70 to 80%, with only 23% cancer patients accessing cancer management services that they actually require. That's according to the MOH. Now, some of the reasons for the late diagnosis are lack of awareness, inadequate diagnostic facilities, lack of treatment facilities. Some patients have to walk long distances. They're referred to come, say, to KLH or KU from all over the country, and it's costly for them to do so. High poverty index. And then according to the Kenya Household Health Expenditure and Utilization Survey and World Bank data, it's revealed that nearly 1 million Kenyans fall below the poverty line due to health-related expenditure. Now, the number of radiation centers in this country, and this is important because when you talk about cancer management, most of the time you are talking about availability of surgical skills and surgical facilities. You're talking about availability and capability of giving chemotherapy where indicated, and most often they may also require radiotherapy. So the number of radiation centers in this country, there are around 10 of them. 7 of them are concentrated in Nairobi, in KNH, in KU. KU, as you remember, has a PET scan and a cyber knife, which was launched by the president the other day. MP Shah, that is the Cancer Care Kenya, Nairobi Hospital, where we are at the moment. The Aga Khan, Texas, Nairobi West, and of course we have MTRH as one of the other main centers in this country. We do have county and regional cancer centers. Mombasa, Nakuru, and Garissa, they have installed radiotherapy services. The others like Kisumu, Kisii, Nyeri, Kakamega, most of these are limited to chemotherapy services. Now this is data a while ago. It's not complete, but this is what was reported 6 years ago. We had very low numbers of specialists in this country. Of note, it was reported then that we had 4 gynecologic oncologists. At the moment, we are over 16, and that is part of the action in terms of human resource capacity building for this country and for gynecological cancers. And the others, as you can see there, the oncology nurses used to be around 3. We have around 60. Medical physicists, they have also increased accordingly. Now, this one is from the National Cancer Institute. The latest count, according to their data, is around 58 oncologists. We are talking generally about oncologists in this country, and 60 oncology nurses, 12 oncology pharmacists. And there are around 19 external beam radiotherapy machines in this country, with 8 units being in public hospitals. This falls short of the recommendation by International Atomic Energy Agency, which regulates such technology, of at least 1 machine per million population. In 2019, only 0.5% of the overall health budget was spent on cancer, despite the disease contributing to almost 10% of the overall disease burden in the country. So you can see the deficit in terms of financing, and I'm not sure whether that also reflects the commitment that we have as a country in terms of tackling cancer. In terms of local training programs, we have some in Nairobi, University of Nairobi, others at Aga Khan University, at Moi University, and we also have oncology nursing training in KNH at Aga Khan and also at KU Hospital. That is in terms of the training locally. Now, what are the initiatives by the government of Kenya? I'm sure a number of us here and those online, you may have been co-opted into technical working groups. You can see familiar faces whom we have met in those technical working groups. There's the 2012 Cancer Prevention Control Act, which is in place. There's been establishment of the National Cancer Institute, Kenya. At the moment, they have their main offices not far from where we are at the moment at Nairobi Hospital, at the landmark building. There's been, NHIF has really, in terms of cancer treatment, we can attest, they have tried as a body in terms of funding cancer treatment. From what it used to be, paying just for the bed, to currently where NHIF does pay for surgical packages, chemotherapy, and also radiotherapy. It may not be fully funded, but at least it's an effort which has been in place for the last few years. In this year, between the 2nd and 4th February 2023, there was the first ever cancer summit in the country. It was held here in Nairobi during the to mark the World Cancer Day. In July 2020, the MOH launched the new cancer control strategy, a national effort to address the growing burden of this disease in the country. The ministry also proposed a nationwide lifestyle modification campaign and prioritized efforts to increase awareness about cancer. It also launched the breast health awareness campaign, pilot report. Just to recap, the MOH has also established 10 county-level chemotherapy centers, as you can see over there, and also provided diagnostic equipment to some counties in terms of X-rays, CT scans, ultrasounds, and mammography. And there has been ongoing effort by the government to establish radiotherapy centers. I think the one of MTRH and KU are almost complete. Mombasa, Garissa, and also Kisii County, they are also ongoing. The government has also, and we are part of that, as gynecologists in this country, cervical cancer screening, the Via Vili cryotherapy see and treat initiatives. Equipment have been supplied and trainings have been ongoing. And January is usually marked as cervical cancer month. It never used to be marked in Kenya, but I think we are running like the second or third year in a row. There's also dissemination of national cancer screening guidelines to all the counties. And the HPV vaccination has also been rolled out for the girls aged between 9 and 14 years, and it's available in most public hospitals. So to finish off, let me summarize the barriers to cancer control in this country. Inadequate cancer care infrastructure, inadequate financing, as we have seen. There's reduced priority among competing interests. And in terms of NHIF, it is inadequate. As much as it's trying, it's inadequate, and patients have to rely on families and communities to fundraise for their treatment. And 80% of this country, at least from the latest data that was accessible to me, is not covered by any insurance plan. And usually, cancer treatment leads to personal financial bankruptcy, and patients are unable to complete their treatments. There's limited human resource capability or capacity. This is coupled by inappropriate use of this human resource, like say having a gynecological oncologist being appointed to an office job, which often also happens. There is delayed presentation and lack of awareness about cancer. If you look at the public, general public, and also among even the healthcare providers. You may be surprised when you talk to healthcare providers, and they have also misconceptions. They may advise a patient not to eat red meat, not to eat eggs, not to eat sugar, not to take sugar in their drinks, and such like. So we tend to have propagation of myths, which we actually do even ourselves as healthcare providers, and that is also lack of awareness among us. So we are finishing, basically we are finished. So what are we saying? We are saying that we must innovate new ways of outpacing cancer, and that is why we are here, basically reviewing what has been happening, what is happening currently in this country, and then at the end of it, also devising ways of how we can operate better in terms of addressing the monster that is gynecological cancers. Thank you very much, and be blessed.
Thank you, Dr. Maranga, for that riveting presentation. Indeed, I think we do have a lot to do in order to outpace this animal called cancer. And I'd like to wish a very good morning to each and every one of you. Dr. Paul Koigi is my name. I am the co-chair for this session, as well as an obstetrician gynecologist here at the Nairobi Hospital. So I would like to take a moment to introduce our next speaker. And before we do, I'd like to offer a round of applause to Dr. Maranga. So, about our next speaker. To begin with, he is a very tall gentleman. His name is Dr. Benjamin Eliodongo, and he is a consultant obstetrician gynecologist as well as a gynecologic oncologist. And he is a very senior clinician with over 22 years of experience in clinical practice, as well as experience in programmatic leadership of public health initiatives. He is currently a senior lecturer in the Department of Obstetrics and Gynecology at the Kenyatta University School of Medicine. He has previously served as the head of the Department of Gynecologic Oncology at the Moi Teaching and Referral Hospital in Eldoret at Moi University. He is also a published researcher and in the process of developing multiple protocols, and he has presented in multiple local and international conferences and participated in various reproductive health discussion fora. He is the immediate past president and also served as the acting chief executive officer for the Kenya Obstetrics and Obstetrical and Gynecological Society. And in this capacity, he provided outstanding leadership as well as strategic direction for a professional body that represents over 400 Kenyan obstetricians and gynecologists. So let us take this moment to welcome Dr. Benjamin Eliodongo. Karibu sana.
Will I use this one or I hold this one? When I was driving to this place, I received a message from one of our colleagues, and the question was, what will she do with a patient who underwent a total laparoscopic hysterectomy for what was thought to be fibroids, and methylation was done, and the final pathology report shows that it is actually endometrioid cancer of the uterus. And this got me thinking that we need to speak more about how we can link diagnosis, screening, diagnosis, and the patients into the care systems. So I've already been introduced, and thank Dr. Paul for that kind introduction. There are two components of early detection of cancer, and this includes early diagnosis, which is also known as downstaging, and screening. So I'm just going to break it down a bit, and we now know that early diagnosis is usually for detection of patients who are already symptomatic, but screening involves patients who don't have symptoms at all. And as you can see, we have made a comparison of what a screening test vis-a-vis a diagnostic test is, whereby screening is done on apparently healthy people. My economics are not so good here. Everything is low here. I don't know. Let me move back a bit. Can the table be adjusted? I don't know. As high as possible. Okay, but we will proceed in the interest of time. So screening test is done on apparently healthy people. It's done in groups, mainly done by epidemiologists, and the test results are final, the purpose of which is usually for community diagnosis, usually less expensive, and the initiative is usually from the programmatic context. Or on the other hand, diagnostic test is done on sick individuals, and mainly done by the physicians, and the initiative is actually the patient who has presented with the symptoms. The diagnosis is not always final because we must correlate this with the history and clinical finding. It's usually more expensive, and initiative is mainly from the patient. And this is just a depiction of what I've said in the previous slide, that screening is mainly for those who are not having any symptoms, but early diagnosis is already those who are symptomatic. And what guides the principle of screening? There are several points that guide this. This has been adopted by the World Health Organization that the condition should be an important health problem, like cervical cancer. There should be a recognizable latent or early symptomatic stage. Also, cervical cancer fits in this. The natural history of the condition should be fully understood, and there should be recognized treatment for the disease, because there is no need of having a screening program and not offering treatment. And the facility should be able to conduct the screening, and the screening should also be affordable. And this brings me to the point of that the best time to conduct the screening is whereby the best time where the screening is more effective if the condition or the disease has a critical point. This is just a summary of what I've said, that screening is done apparently on healthy individuals, whereby the test can either be abnormal and or normal, whereby patients are followed up. We as a country, we are now moving towards having more programmatic and organized screening as opposed to opportunistic screening. Like I said before, that everything has risks and benefits, so there are benefits that can accrue from screening as well as risk, and the benefits include improved outcome, less radical treatment, and assurance in terms of decreased anxiety. But on the other hand, the screening can lead to overtreatment of conditions, longer morbidity for those patients who have got a disease that cannot be unaltered, false assurance, high anxiety, and also the hazards of screening, including the use of radiation. As public health specialists, we should also understand that we measure what we do in terms of short-term outcomes, which could include the number offered screening, number who received screening, and vis-a-vis the long-term outcomes, which include the case fatality rate and cancer-specific mortality rates, amongst other costs of screening. Despite all the efforts that we have put in place as a country, we still have patients who are coming to us with really delayed diagnosis. And we found that what leads to delay in diagnosis and treatment includes access delay, which Dr. Maranga has already alluded to, includes poor cancer awareness. Diagnosis delays in terms of poor performance, referral issues, and treatment delays, because patients wait for very long before some of them wait for quite a considerable amount of time before they can get treatment. And all this is anchored on the foundation of financial barriers, logistical barriers, and psychosocial barriers. So I'm going to go to disease, to specific conditions to see how we conduct screening and early diagnosis for these conditions. So let's start with endometrial cancer, whereby we more often than not have had women who come to our care with postmenopausal bleeding. Many times, like the case I've just given when I was coming over here, that a surgical intervention was offered, but apparently was not the right one. And this could have been avoided by proper screening and diagnosis. And for women who come with postmenopausal bleeding or abnormal uterine bleeding, it's easy to do an endometrial biopsy, which can be done using a pipelle, which has over 98% sensitivity. Usually, formal D&C is not required. Where resources are available, we can do a hysteroscopic biopsy. And this slide is thanks to Dr. Francis Were regarding one of the patients we managed with him. We did an endometrial biopsy for a woman who presented to us with postmenopausal bleeding, and the endometrial biopsy had actually shown that patient had squamous cell carcinoma of the endometrium. And we couldn't believe it. So I asked Dr. Were, who has the capability and the technical know-how to do a hysteroscopic biopsy, and this is what he found, and biopsied the specimen, still was reported as squamous cell carcinoma of the endometrium. We are moving towards the molecular and classification of endometrial cancer. And currently we now can do immunostains for the mismatch repair genes, which includes MLH1, MSH2, amongst others. And the presence of these proteins in a stained specimen rules out the presence of the Lynch syndrome. In the interest of time, I'm going to move very fast to ovarian neoplasms. And this is just a depiction or a cartoon showing the various, the ovary in terms of where the cells that have malignant potential. And you can see the primordial germ cells is where we have the germ cell tumors arising from. Then you have got the supportive structures of the ovary, or 10 more minutes. Supportive structure of the ovaries, you have got the sex-cord stromal tumors, which includes fibroma, thecomas, and the rest. And then the coelomic epithelium, where we have got the epithelial cancers. And from this, we can leverage on tumor markers. And tumor markers are used for screening, diagnosis, prognosis, monitoring, treatment, and detection of recurrence. And tumor markers can either be enzymes, hormones, oncofetal antigens, receptors, tumor-associated proteins, and genetics. And with these, tumor markers can be determined, or the levels can be determined by doing serum tests. Like this way, we call them serum tumor markers. So if a woman comes with an adnexal mass and you're really not sure whether it's malignant or not, this can act as a guide as to what kind of tumor we are dealing with. For example, CA125 for epithelial ovarian cancers, especially the non-mucinous type, because we now know that the mucinous types you can use CEA. But for germ cell tumors, especially young girls, adolescents who come under adnexal mass, should not be in a rush, but we can really do the preliminary test, which includes LDH, which can suggest that the patient could be having a dysgerminoma, AFP for endodermal sinus, also known as the yolk sac tumor, beta HCG for the non-gestational choriocarcinoma, and of course serum inhibin for granulosa cell tumors. CA120, many times we see patients who have had a CA125 done, especially the premenopausal women. We now know that specificity of CA125 is low in premenopausal women, because it can be affected by common benign conditions. This includes endometriosis, PID, fibroids, benign ovarian cysts, functional cysts, even menstruation, pneumonia, colitis, connective tissue diseases like SLE. However, in a postmenopausal woman, CA125 has a very high positive predictive value, especially in the epithelial tumors. However, it is only positive in 25 to 50% of stage 1 disease. Many times, or occasionally, we see patients who come to us with an adnexal mass. You are not sure whether it's benign or malignant, and whether the patient should be managed by a general, by the general gynecologist or by a gynecological oncologist. And sometimes you are in a dilemma. You see this 50-year-old woman with an adnexal mass, and how do we now cascade the care? There is a concept of the risk of malignancy index. This takes into account the ultrasound features. And many times if you do an ultrasound of an adnexal mass, there are some features that can suggest that it's malignant. For example, if it's multiseptated, it has solid and cystic areas, increased vascularity, presence of ascites, and this can be correlated with the CA125 in the scenario of risk of malignancy index. And it's easy to calculate because you assign scores depending on the features you see on ultrasound. For example, if you see only one feature, you give a score of 1. If you see more than 3 features on ultrasound, which means maybe the patient has ascites, has multiseptation, has solid and cystic areas, and then you multiply that with the menopausal status. If the patient is premenopausal, you multiply by 3 and premenopausal by 1, and the absolute value of CA125. Many times if you get a value of more than 200, then that's also your antennas go higher, that probably you are dealing with a malignant condition, and you link this patient to appropriate care. There are 2 kinds of RMIs. So there's RMI1 and RMI2. RMI1 is what I've just described. RMI2 uses a score of 4 for postmenopausal status. I have no experience with over 1, but this is a mathematical formula whereby one can detect the presence or absence of, or the likelihood of having a malignancy using markers like CA125, prealbumin, apoprotein, transferrin, and beta-2 macroglobulin. Cervical cancer is the leading cause of morbidity and mortality, and there are ways that this has been eradicated or in developed world, and we can adopt this using the pap smear, which can either be the traditional pap smear, whereby you obtain the specimen and put on a slide and fix, or the liquid-based, whereby the brush is put in a liquid medium. It decreases force, negative rates, it decreases sensitivity, and it can also allow concurrent HPV DNA testing. To avoid false results or results that are not reliable, it's good to collect before by manual examination. Do not contaminate with a lubricant. Collect before an STD. Ensure that you visualize the entire cervix. But what do you do with the results? We have come across cases whereby straight ahead, healthcare providers or gynecologists go and do a very radical surgery or simple surgery based on a pap smear. But what do we do when you have abnormal pap smear? You see, I've put what I've marked in red, whereby you have got NS, L-seal, H-seal, carcinoma, or AGC. Actually, one is supposed to do a colposcopy to guide the next course of action. And this is just depiction of what satisfactory colposcopy is, whereby the entire transformation zone is visualized. And how do you know you have the transformation zone is by the outer aspect, the outer margin is by the Nabotian cysts. And this is unsatisfactory colposcopy because you can see the transformation zone is kind of going into the endocervical canal. The role of HPV testing has already been introduced in the as recommended by WHO in the 1970-90 strategy. So HPV DNA screening is an armamentarium for screening for cervical cancer. But the handicap is that there is a cost involved in it. Having said about cost, we should not abandon what we have in our country in the low resource settings. This includes the use of acetic acid, which is based on the principle that tumor cells have high protein content that get denatured and they stain white, or villi, based on the principle that tumor cells with less glycogen don't pick up the Lugol's iodine. And I just put on a few pictures of what you can see. Like this was after staining with acetic acid. This is normal. We can only see advancing squamous metaplasia. This was also normal, but this was a postmenopausal cervix. You can see the squamocolumnar junction is entering is more inside the cervical os. This shows that there is an acetowhite lesion on the anterior lip and a satellite one on the lower lip. The same as this one, there is acetowhite lesion based on the use of acetic acid. We use iodine also, and this was normal. You can see it all stains brown. But look at the next one, you see there is a place that did not take up the stain. It stains yellow or banana yellow. So moving on to vulva, many times we see women who come with chronic itchiness. We call it the itch scratch cycle. There are two kinds of vulval cancers. Type 1, which is, of course, Dr. Maranga had mentioned, associated with HIV and HPV, and type 2, which really takes the P53 pathway associated with itching and scratching. And it's easy to make a diagnosis, mainly using a Keyes punch biopsy forceps, whereby you clean the vulva and kind of just rotate it and get the specimen. So I've really tried to rush over this, but just mention a bit in summary that screening of cervical cancer involves cytology and HPV testing. There's really no screening for endometrial cancer, but diagnosis can be made early by doing endometrial biopsy. The same applies to ovarian cancer, but diagnosis can be made with the help of tumor markers, RMI, amongst others. For vulvar and vaginal cancer, annual physical examination and biopsy. Thank you very much for listening.
Thank you very, very much, Dr. Eli Odongo, the tallest man in the world. You've actually saved some 2 minutes. Do members in the audience have anything burning, or we can let him sit down and talk later? Okay. Oh, okay. Please, we've saved some time so we can ask a question.
I have a lecture that is on KU.
Okay, thank you, sorry. Thank you very much, Eli. I think that's quite okay, no problem. Thank you. No problem. It's okay.
About methylation, because
Okay,
the
so
second
thank
question.
you. Now coming to the other one is screening. Now looking at the endometrial cancer, which sometimes could be localized. I'm sure nowadays we are looking more at seeing and treating and targeted biopsies.
One, yeah, the self-sampling for HPV DNA screening. We did some work with Dr. Anissa in Eldoret, and we actually have published regarding the acceptability and the use of the self-sampling using the EVA brush. It was it was more acceptable among women because they don't have to come to hospital, and also the fact that they just have to drop it and the results are emailed to them. But on the other hand, we must look at how many of our population can actually afford that kind of care or that kind of intervention. Pretty few. So we should also not abandon our traditional screening methods. And then the second question was on the, oh gosh, I should have written it down.
On the diagnosis for hysteroscopy vis-a-vis use of PSET and for endometrial cancer.
Yeah. For endometrial cancer, especially women who come postmenopausal bleeding, it's advised always take a biopsy, and we can easily do it using a pipelle. It has a 98% sensitivity actually. But where resources are available, it's good to do under direct vision. Like the patient, I mean the slides that were shared with me by Dr. Were, the reason why we actually did this, pipelle had actually picked it, that this thing is squamous cell carcinoma, but we didn't believe that squamous cell carcinoma can arise from the endometrium. And that's why Dr. Were did this particular hysteroscopy and actually showed there's a mass and the diagnosis is the same, but where the resources available, direct vision definitely is much better because you don't miss the 2%. Methylation, Dr. Alfred? comments on methylation? Because personally, I have issues about methylation. We have guidance on that. Yes. You are next as you comment on methylation. Yeah, because
for everything, and it's not superior to open surgery, just like open surgery might not be superior. So case selection.
Thank you very much. Dr. Odongo, allow us to appreciate you. We really appreciate the time you've come and spent with us. And we have at the University of Nairobi, the University of Nairobi. He's also a senior specialist at the Kenyatta National Hospital. Dr. Mukomba, please, you're very welcome. Take it away. Thank you.
Thank you. And is this one? Yeah. Thank you for the welcome. I think we are also privileged to have Professor Ojwang joining us live. And Professor Karibu sana, most welcome. So my topic is more of a formal talk. My colleagues have taken you through more of the public health and the screening initiatives. We slot in this so that we are able to at least cover one of the malignancies. Adjust the technology. So mine was to basically cover the management of C endometrium. It's an overview, it's a very large topic which cannot be covered comprehensively in 20-30 minutes. So it's a quick overview. It's not moving. Okay. Yeah, so basically it's an overview of what you expect when you do surgeries. You can get a focal discrete lesion. It can present as an endometrial polyp or a diffuse growth in different areas, or it can be covering the entire endometrial surface. That's in terms of the anatomical presentation. But back to the basics, in terms of epidemiology, normally it's a disease of the elderly, but doesn't mean younger women cannot get this particular condition. So majority are in those who are in their 6th, 7th decade and above, and a smaller percentage in those who are under 40 years of age. So in the West, because they have registries and statistics, it's the commonest gynecological malignancy. For our country, and especially though we don't have hard statistics from our observations in the various centers, it's more or less like the 4th commonest gyne malignancy in our setting, but we are seeing endometrial CA cases more and more. I think as Dr. Maranga alluded, as people get more of the lifestyle diseases and the life expectancy increases. So the hard facts we have about the figures which we get from the West, but that's how it is. I think in our country, with Global Can 2020, is about number 23 among the causes of cancer. Probably we'll have more as we advance in reporting and improving our cancer registries. So what are the risk factors for patients who get endometrial cancer? Age is a big factor. As you age, the risk of getting any malignancy increases, and for this particular one, those who clock 60 and above, then the risks are increased. Obesity, those who are diabetic, and we know those people with diabetes in our country, the incidence is really rising, so the risk of this particular condition also will increase. Basically, these are risks associated with high estrogen levels in the body, hyperestrogenic states. That's where the aspect of obesity, diabetes, and all that comes in. Those with the polycystic ovary syndrome, those who are nulliparous, those who have never breastfed, they are at risk of getting this condition. And not to forget those with the genetic predispositions, things like the Lynch syndrome, BRCA, the BRCA mutations. These people are at risk of getting endometrial cancer, among other conditions. Those who are diagnosed with endometrial hyperplasia, if it's not taken care of, there is a significant risk of developing endometrium along the way. Yes, that is the risks of those with endometrial hyperplasia. If there is no atypia, then the risk is less. Those with atypia, hyperplasia with atypia, then the risk is as high as 28% if it's complex. There are some protective factors, like the use of oral contraceptive pills, and it's because the oral contraceptive pills tend to, they confer a protection of about 33%. The higher the parity, the more the protection, though we still see our women who are even para 8, para 10, but with the other factors now, like obesity, diabetes, coming up with endometrium. So on its own, it is not protective if the other risk factors are there. It said breastfeeding reduces the risk. Things like smoking reduce, but you wouldn't advise anybody to start smoking so that they are protected from endometrial cancer. And this is because I think it induces atrophy of the endometrial lining, and this probably gives that protection, but like I said, that's not something one would advise. Okay, then how does it present? Normally it should be picked early because it presents with abnormal vaginal bleeding, especially at the perimenopausal and postmenopausal ages. But we know why it doesn't present as early as it should because of the myths around abnormal bleeding. Our women will not talk about it until they are overwhelmed. Either the bleeding is excessive or something else comes up. You might go home and your mother will never tell you she's bleeding unless you are very, very close. So it is one of those myths we need to break, that if somebody is having abnormal bleeding, they should be able to report early. As the malignancy advances, there might be abnormal vaginal discharge. If the uterus is enlarging, it can present with an abdominal pelvic mass of various sizes, non-constitutional symptoms, if it's now spreading beyond, like bloating, constipation, early satiety. And then in those who get metastasis, signs and symptoms that represent the particular areas. For example, if it's the chest, one would be having a cough, can have hemoptysis. If it's in the CNS, then can present with CNS symptoms, signs and symptoms. But by far the earliest presentation is abnormal bleeding, and like Ellie said, we should take it seriously and investigate it as appropriate. Just a little bit on the types of endometrial cancer, just an overview. We know there is type 1, which is estrogen dependent and tends to be endometrioid. Of the endometrial type in 80%, you can have other types like mucinous. And most times this tends to be the one with good prognostic factors. And the main risk here is hyperestrogenic states, hormone replacement therapy, obesity, and the like, unlike the others where it's more to do with the genetic mutations. If it's caught early and treated early, then you tend to realize then we tend to get good outcomes, and the survival is much, much better than the other type. So this is type 1, estrogen dependent. Then you have the type 2, which is non-estrogen dependent. And this is where now you have all those genetic mutations, the Lynch, the BRCA, the mismatch repair genes, and all that. And it's non-estrogen related, like we have said. It tends to affect the older women. And most of the subtypes are very, very aggressive, and they require equally aggressive therapy. And in terms of treatment, they are all classified as high-risk subtypes, therefore needing more aggressive treatment. I think we don't need that in the interest of time. So all those are the type 1 subtypes. Yeah, this one is important. This is a type 2 endometrial CS subtype, serous. Just like for those who know, we also have serous of the ovary. They tend to behave almost the same way, very aggressive, not estrogen related. It's a high-risk lesion, and sometimes by the time a diagnosis is made, it has spread beyond the uterus. And like the professor tells us, most of the times, once it runs out of the uterus, then the horse has bolted. And it becomes quite challenging to treat. That's why the purpose of this is to emphasize in terms of the management that we should not just have, once you have done that hysterectomy and you consider that as complete treatment. There's much, much more than this. Yeah. So apart from this, the other commoner one, it affects like 5% of our patients. Clear cell, also very aggressive, a type 2, which also is high risk because of its level of aggressiveness. The pattern of spread is quite fast. And once a diagnosis is made, then you should institute aggressive treatment so that you give that patient a chance. Okay. Also, not to forget, you can have malignant tumors metastasizing from other organs to the uterus, from the ovary, from the cervix, from even vulval cancers. You can have tumors of the GIT system with a metastasis to the uterus because the cross connections of the lymphatic flows, the blood supplies, and the like. All right. So staging, I won't go much into that. Although it affects treatment, this is just broad. There's a more comprehensive stages. Stage 1 if it's within the uterus. Stage 2 if it's involving the cervix. Stage 3 if it's going to involve the lymph nodes and the surrounding organs. Then stage 4, now the horse has really bolted to the bladder, rectum, and to distant organs. So this is where now it's important. How do we now manage this condition? If we get these women who come with abnormal bleeding, the most important thing, of course, the supportive investigations. You still need to do screening for any cervical lesion with either pap smear or colposcopy as appropriate. An ultrasound can be of use, and if you get an endometrial thickness of more than 5 millimeters, that should be of concern. But most important is endometrial biopsy. Whichever mode you use, you should not proceed to do hysterectomy without having done endometrial biopsy, so that you know the subtype, and that will dictate the extent of surgery you are going to perform. Whether you are in a setup where you only have access to dilatation and curettage, you'll still be able to get something. If you are able to use an office pipette and it gets you a good sample, that is good. If you are in a setup where you are able to do hysteroscopy and do direct, you take a biopsy under direct visualization, that is good enough. But in whichever setup, there are all those options that you can undertake, and you'll get a diagnosis. Like I said, if you get the histology, if it's endometrioid, then you know you might scale down the extent of surgery. If it's serous, you might want to do more aggressive surgery. So that's why the rationale for doing an endometrial biopsy. Most times patients will request, they'll say, if you are going to do a hysterectomy at the end of the day, why take me to theater twice? Why can't you just, we go for the hysterectomy straight and we finish this thing? But that can result in either mostly under treatment, which reduces the chance for the patient. Okay? I hope I'm almost there. And also, once now you confirm with the endometrial biopsy, then if you are in a situation where you have MRI services, then you can do an MRI. It gives you a kind of staging whether the lesion is involving the cervix. As it spread to the bladder, to the rectum, and more importantly, are the pelvic and aortic lymph nodes enlarged or not? So that helps you to plan, and they should be able to tell you whether the lesion is eating into the myometrium, it has gone beyond the endometrium into the myometrium or not, so that you're able to plan and advise the patient accordingly. So that's in terms of the investigations. So the definitive management, which will be surgery and then adjuvant treatment, will depend on whether the tumor type is high risk or low risk. Like I said, if it's endometrioid, you might want to be a bit moderate in the management. If it's high risk, then you are more aggressive. The level of differentiation, which the pathologist should be able to tell you, if it's a well-differentiated, probably it's a low-risk tumor. If it's poorly differentiated, then it's high risk. The potential for spread to the lymph nodes and surrounding organs is higher, therefore your treatment will be more aggressive. So these are the factors to consider when deciding what extent of surgery one will do. And also the staging. Though staging is surgical, but if you do the MRI, it will guide you. If the tumor is just limited to the endometrium, then you might want just to go for a simple hysterectomy and you get away with it. For example, if it's involving the cervix, then you treat it like you would operate for a cervical cancer lesion with radical hysterectomy and lymph node dissection. So this is important. And if from imaging it shows it has gone beyond stage 1A, then you'll advise the patient that she might require post-surgery either chemotherapy plus or minus radiotherapy, depending on what you get after you do the eventual surgery. So this is very important in determining what you are going to do. So the first step, of course, is surgery. If it's endometrioid stage 1 and it's a grade 1 tumor, then you might want to do the hysterectomy and bilateral salpingo-oophorectomy. And remember, you are doing a staging, so take peritoneal fluid, or if there is ascites, you take the fluid for cytology. Survey all the organs within the abdomen to see whether there is any involvement before you do the hysterectomy and bilateral salpingo-oophorectomy. Sometimes you might want to sample the lymph nodes for purposes of staging. There is no clear consensus on whether doing lymphadenectomy offers, improves the overall survival, except where the lymph nodes are so big and you are reducing the tumor bulk. But what we know for sure, it does help to improve your staging, which will dictate the type of treatment you'll give this patient post-surgery. So if it's a tumor that has gone now to involve, it is a 1B or it's involving the cervix, then one will do a radical hysterectomy and pelvic lymph node dissection. You might include, you sample the paraiotic lymph nodes and submit it for histology. And these are patients, if it has gone 1B or stage 2 and above, then you will give adjuvant therapy in form of chemotherapy, and later you'll decide whether you are giving external radiation or you are giving vaginal brachytherapy. For example, if the lymph nodes are positive, then you'll give both external and vaginal brachytherapy. But in most cases I've read, if you have given the external, then they say the vaginal one doesn't add a lot of advantage. So you'll assess the histology after this surgery will dictate the full extent of treatment you are going to give post-surgery. And you should be able to look at the pathology report. I'll show you a sample, and you are able to analyze all those factors, and you decide whether you are dealing with risks that can give recurrence if you don't give another treatment or not. Okay? Yeah, I've already talked about that. If it's the type 2 endometrial cancer, of course, no, you are going to do, for example, the hysterectomy, bilateral salpingo-oophorectomy. If it's serous, you might want to sample the omentum, and also you sample the lymph nodes for purposes of staging, but you will have to give post-surgery adjuvant chemotherapy and radiotherapy depending on your findings on histology. Okay? I think in the interest of time, I think we've covered that. So apologies for I wasn't able to blur out the patient details. That's one of the reports you can get, you see, sorry, where the pathologist gives you all those, the histological types. It tells you the grade of the cancer and whether your margins are free or not. And finally, the pathologist should be able to tell you whether the lymph nodes are positive or negative, lymphovascular space invasion, so that from this, then you are able to make a decision on how you are going to manage the patient post-surgery. So the emphasis is on, you must be careful to assess the risks so that you're able to offer the patient treatment beyond the hysterectomy and bilateral salpingo-oophorectomy. Most of the patients will need further treatment to minimize cases of recurrence. I think in the interest of time, I'll end there.
Thank you so much, Dr. Mokomba. Yeah. And since you have actually saved us a few minutes in the process, yes. I think we have another 2 minutes to go. Yeah. Who has a question for you? Yeah, include
recurrence in cases of endometrial cancer. That is the most common site of recurrence in patients with endometrial cancer. And that's why where the lesion is beyond stage these conditions at a very early age. Of course, we are limited by unavailability of so that by age 40, then you probably are able to do prophylactic hysterectomy. And then later they can use on a surrogate to get children. Dr. Maranga maybe can comment on that.
Endometrium, then you subtract something like 10 years and you actually do, you may advise for other procedures like prophylactic mastectomy, depending really on the criteria and the risk, or prophylactic salpingo-oophorectomy. So those are some of the options, but I think in terms of actual management, it has to be individualized. My last comment, my comment apart from that, if I may be allowed, is really, thank you, Dr. Mukomba, for that engaging presentation. Mine is to emphasize again the bit about proper description request to the pathologists. If you have engaged the pathologist, you'll actually realize that our requests generally tend to be inadequate and wanting. They will actually tell you that sometimes they get a specimen and they're told to do histology. They don't even know which site, which type of surgery was done. And if you really want a proper report, one of the most important things, even when you have an assistant or an intern or a resident, is actually that request form. Because then you're able to, you know what you have done, you know what you have. Could you give me more description? Is it endometrioid? And if it is endometrioid, what's the grade? Is it grade 1? Is it grade 2? Is it grade 3? Is it clear cell? Is it serous, just like Dr. Mukomba has presented?
quite a number with endometrial cancer. With regard to management of breast, yeah, I think
Thank you, Professor. And we'd like to express our gratitude to Dr. Mokomba for Baraza. He is a medical doctor with 14 years of expertise in HIV and reproductive maternal child health and adolescent health programming. He also is an expert in research and health system strengthening. As a member of the senior management team and a consultant in various organizations, he is well versed in grant management, coordinating health activities in the districts, devolved and national health systems, policy formulation and implementation, cost efficiency, health systems research, and resource mobilization. So academically, Dr. Chris Baraza holds a bachelor's degree in medicine and surgery, a master's degree in business administration, and a master's degree in obstetrics and gynecology, all from the University of Nairobi in Kenya. He also holds
difficult for clinicians, but it's possible actually, that for the next 20 minutes, we start thinking about very fundamental things that by the time a patient arrives to your desk as a gynecologist, what's the pathway that they have taken to be there? So I'm currently doing some work with AMREF, and AMREF is focusing a lot on primary health care. And the country now, if you go to the Minister of Health now, the CS for Health, and you start talking about primary health care, they listen to you. If you go there and say, I'm a gynecologist, they may take a bit of time before they listen to you. But if you go there and start saying, I'm coming here and I want to talk about primary health care in relation to cancer, they'll actually listen to you and give you an audience for you to, because those are the policy makers, those are the decision makers. They determine what you are going to do here. So we are focusing a lot on that in terms of just how can we have the bottlenecks in cancer pathways taken care of, And then I'll focus a bit more on public partnerships in cancer care, and what are some of the opportunities that we see out there from a public health perspective. So a few reflections, some questions that the team here can think about. I'm not so sure you have this data, but in case we don't, then again, for those of us in academia, these are important questions that we may want to think about. What's the average time taken from symptom presentation to diagnosis of gynecological cancers in Kenya? Do you have that answer? If anyone has that answer, please just feel free to interject. The second question is, what's the average turnaround time for diagnostics for cancers in Kenya? And I have a case actually that I've been following up. From the time you do the surgery as a gynecologist to the time you get the results, how long does it take? Okay. How long are you telling our patients to come back for review? After 2 weeks? After a month? Okay. In Bungoma, where I come from, there's a patient who had a hysterectomy done. They were suspecting cancer. 6 months down the line, and the patient has not gotten the results. Are we seeing similar situations here? When you go to Turkana County, where sometimes we do some work, you may never actually see the results. Or by the time the results come back, the patient has actually passed on, for that matter. So very critical question that we need to ask ourselves in terms of diagnostics. Which cadre of staff are largely involved in the management of gynecological cancers? Dr. Maranga mentioned that we have 16 gynecological oncologists in this country. What's the largest proportion of, are they clinicians? Are they nurses? Are they medical officers? Are they even quacks, okay, in the villages that are actually taking care of this patient, saying that they have been bewitched in those villages? So by the time the patient reaches here in Nairobi, who are the cadre of staff that have been involved in this management? And then the last thing that I wanted to think through as we reflect over this is, what's the average cost of managing a patient, for example, with cervical cancer in Kenya? So this picture has been presented very well by Dr. Maranga. I don't want to go back there. But this was estimated in 2007 by the UN that indicated that actually we are going to have a rise in cancers across the years. And the critical questions we are asking ourselves is it because of urbanization? Is it because of climate change? Is it because of pollution that you are seeing? Is it because of poverty? Because there are some cancers that have been associated with increasing poverty levels. Is it because we have an upsurge of infectious diseases? Of course, some cancers are related to infectious diseases. Or do we have a genetic predisposition? Do we have a mutation that is happening somewhere that we haven't picked that may be leading to the worsening picture of cancers? And what are some of the global strategies that we have? Cancer of the cervix is the well-documented, very well-documented cancer. And as Dr. Odongo mentioned, because of the various reasons that we have, it takes a lot of time. By the time a patient presents with symptoms of pre-malignancy to the time of developing cancer, it takes time. So a lot of things can actually go wrong, at the same time can go right. So the WHO has targets for cervical cancer screening, or rather elimination of cervical cancer by 2030. And the point is that to reach and maintain an incidence rate of fewer than 4 new cases of cervical cancer per 100,000 women per year. Dr. Maranga presented here the incidence in Kenya. Are we anywhere near there in as far as our country is concerned? 2030 is just about 5 years away or 6 years away. Are we even anywhere near what you're talking about? The second thing is at least 70% of eligible women are screened with high-performance screening tests. Where are we in our screening approaches to cervical cancer? Are we at 20%? Are we at 30%? Are we at 40%, objectively speaking? Are we likely to get to 70% in the next 6 years? Very important question that we need to think about and ask ourselves. At least 90% of women with cervical pre-cancer are treated, and 90% of women with invasive cervical cancer are managed. With 16 gyne-oncologists, the population of over 48 million. What are you talking about? Okay? How is the reach, okay, in the management of this invasive cervical cancer? At least 90% of girls are fully vaccinated against human papillomavirus by age. And I want to mention here that quite a lot of challenges. I was in this farthest part of this country, in Turkana, a place called Loktang. Loktang is just 2 kilometers from southern Sudan. And I was giving a talk to some school-going girls. For information, in Loktang, if it reaches 1, you go to a school at 2, they are new pupils because they have gone home. And when they go home, they don't come back to school because they are too hungry. They can't come back for an afternoon class. So you have to go back the following morning and talk to the girls there. What surprised me, or what was amazing, is the fact that we have HPV commodities in the farthest part of this country. That's Loktang. Okay? We have registers in primary schools in Loktang for HPV screening. But what was very disappointing is that we have a very poor monitoring system in terms of identifying when are we likely to have expiries for these HPV, and some of them actually expiring on those particular areas. So I was asking the team there, do you know the cost of producing HPV vaccine for that matter? So as we talk about this in this country, how can we be able to reach the 90% of girls fully vaccinated against human papilloma virus? This is what we call a Kingdom's multiple streams theory. Is it at play? And what this theory says is that there have to be 3 multiple streams, just the way streams coalesce to form a river. And the river goes into a bigger river, it gets into a lake or an ocean. So the 3 streams must coalesce for any public intervention to be relevant or significant. And one of the words that I've picked out in this symposium is action. So how do we get to action in as far as cancers are concerned? So we must have a problem. And the problem is basically significant public health problem. So escalating cancer cases in the sub-Saharan region is a big problem. It's a problem enough for us to have 1 stream for that matter. The second stream is policies. Dr. Maranga again mentioned about the policies that we have as a country. Kenya has been known to make very good policies. We spend a lot of money in meetings and emails, for that matter, as they call some of us in the public health world. But then we never implement most of these policies. You go to the Ministry of Health, very nice policies. After 5 years, we haven't implemented them, but then we start reviewing the policy that has not been implemented, for that matter. So we have very nice policies, Cancer Prevention and Control Act, the National Cancer Control Strategy, the private-public partnership framework, primary healthcare framework, that can actually guide us in as far as Vision 2030, that can guide us in as far as all that's concerned. But we have the political goodwill. I'm not so sure about that. The willingness of the government to implement the policies. How willing is the government to implement the policies? And not just government, but even the management. Nairobi Hospital, for as an example. Are we implementing some of these policies, or are we leaving them to accumulate dust somewhere? The National Cancer Institute of Kenya plays an advisory role to this. So can we confidently say that our first stream of the problem, our second stream of policy, and our third stream of politics are coalescing somewhere, and the time for action is now? Or are we just having a very nice theme without really thinking about those things? Okay? It's a challenge to all of us. That really, have we looked at what we mean by having an action now, so that we look at all those streams? Because if the 2 of them meet somewhere, as you looked at that figure there, no change will take place until all the streams usually coalesce. Then we have a window of opportunity for us to achieve that. Dr. Tedros was one of the directors at WHO once said, politics is like going against the wind, because politicians advocate for hospital beds. Those of you who have listened to politicians campaigning, they will tell you, when I get into office, I'll create for you another hospital. During elections, even communities want to see something visible, something big, like a hospital, but they never want to listen to something like I'll improve services of a particular hospital. So most of them will want to get into that kind of what we call mortar and sand, for that matter. Primary healthcare at a glance. So the Alma-Ata Declaration of 1978, primary healthcare is key to achieving the goal of health for all. And WHO's priority goal is to enhance public health approaches for the prevention and control of cancer, with a special focus on primary healthcare, as endorsed by the World Health Assembly in 2008 and emphasized in 2011. So one of the things that WHO talks about, again, is enhance the development of strategic decisions to reorient the population-based prevention, in addition to the clinic and hospital-based care policies towards NCDs, and cancer is one of them. Integration of cancer prevention, including early detection, treatment, and palliative care within the context of the national non-communicable disease prevention and control programs. So when you talk about primary healthcare, basically we're looking at 3 prongs. We're looking at a multi-sectoral policy and action, which I've talked about, empowered people and communities, and then integrated health services with an emphasis on primary care and essential public health functions. But most importantly, is to have an essential healthcare based on practical, scientifically sound, socially acceptable technology. Tamaranga mentioned that we have about 54 million phones registered in this country. That means almost, some of us have more than 1 phone. If I do the sample in this room, I think maybe I'm a culprit. I have 2 phones actually. Some of us have even five registered numbers in as far as this is concerned. So in terms of phone technology penetration, actually Kenya is doing very well in Africa. It's actually second to South Africa only, in as far as penetration of the phones is concerned. And therefore technology becomes a very critical role in as far as our primary healthcare interventions are concerned. Universally accessible, so as we do interventions, are they universally accessible? But the end point is, we want to develop what we call self-reliant systems. A self-reliant system that depends on itself in terms of actualization of what they have done. Brazil is a very good example of how primary healthcare has worked. And this is just a pictorial of, it's not very clear, of what they have done. And they did a study to assess their primary healthcare interventions. And some of the findings they had was, there's a lot of need for a country to do what we call social investment. What's our role as gyne-oncologists when you are discussing NHIF and cancer management? Do we sit on the fence and wait for them to make decisions for us? Or do we allow ourselves to go on the discussion table and say that this is what we have, and we must have this? Because you cannot give a same rebate for a patient with cancer the same way you're giving to a woman who is just pregnant for 9 months. It's a chronic disease. What's our role as cancer managers, for that matter? Capacity building to improve socio-demographic indicators. I'm glad actually there's a lot of training is going on, but at what level of training are we having? At what level are we having? Are we going further down to that clinical officer who will be the primary caregiver that the patient really believes in? By the time they hear about Dr. Maranga in Nairobi, we are already in stage 4 of the disease, because the clinician missed out maybe 5-6 years ago. So can we percolate further down in terms of capacity building and just being able to really improve our socio-demographic indicators, even after inserting intermediate structures of health centers, proximal work processes, blocks of variables per capita household income remained significantly associated with lower cervical cancer mortality rates. It's a study that was done in Brazil. And they are saying is, the ability of a household to manage its health-related issues is extremely important. So as you're looking at a patient in Nairobi here, ask yourself, where are they coming from? What is their social strata? What are the economic strata? Are they able to manage the diagnostics? When you tell her that you need to have a radical hysterectomy, and yet she has sold her goat before she comes to Nairobi to see you, what does that mean? Okay? And how can we position ourselves to be able to manage that? Coverage rates for screening programs need to reach 85% to make an impact on cervical cancer mortality, being very deliberate about us. What have we done in Kenya? A lot of discussion has gone on in as far as primary health care is concerned. There's a book here, a policy document that was released sometime last year that talks about primary care networks. And you're looking at having a spoke and hub orientation. So having a hub that has primary health care referral facility level 4 at a level 4 level, and then network of facilities that are attached to it, an MDT team that looks into this, and then having population that is linked to the hub. So the country has been divided into what we call primary care networks across the whole country. And we have over 500 primary care networks. Nairobi has been a bit complicated to develop primary care networks because of the stature of Nairobi. But the question that we are asking ourselves is, where are the private providers in these primary care networks? And what's their role in as far as these primary care networks are concerned? Where does Nairobi Hospital sit in this framework? If you go to the district hospitals, or rather the districts or the counties where we come from, where do the faith-based organizations that provide care to about half of the population come in these primary care networks? Because we haven't seen you on the table. We have been discussing this, but we're not seeing you on the table of discussion. So when you make decisions, where are you in as far as all these discussions are concerned? And I've just asked that question. What's the role of the private sector in the PCNs? Are we relevant as far as diagnostics are concerned, referrals are concerned, technical know-how? Because out of the 16 gyne-oncologists, I think about, Dr. Maranga mentioned that more than 10 are in Nairobi, right? Yes, out of the 16 gyne-oncologists, more than 10 are in Nairobi. Nairobi is just about 6 million people during the day. So what happens to the 42 million people outside Nairobi in as far as access to gyne-oncology is concerned? So technical know-how, how do we manage this so that we can have, yes, gyne-oncologists here in Nairobi, but they can be able to have networks and support. And I like what some of us have done. Dr. Makomba, I hope you still go to Machakos, because I know you used to go there to manage patients there. But such arrangements where actually, as an expert, you can be able to provide your services in a far-fetched area, but be able to support some of these diagnostics for them to come back early enough. There are quite a number of barriers. I don't want to go through this because, again, they have been mentioned before. But I want to go through some of the studies that have been done in Kenya here. And poor access is a critical barrier. Facility consistent predictors of service delivery challenges, including insufficient room. You go to a facility, a sub-district hospital, a district hospital, and you look at the room for even just screening cervical cancer. If I was a woman, I would not be in that room for screening. Okay? Because the couch is as dirty as they can come. You look at even just the room itself, the privacy of the room is not there. So you expect me to come and undress and lie there and be screened for cervical cancer? Of course not. Yeah? Forget about Nairobi Hospital. Okay? Mashinani. Okay? And that's where the majority of the population is. Even forget about Kenyatta. When you used to be trained in Kenyatta, you used to think Kenyatta has poor services. Until you go to the county hospitals, you realize you're actually in heaven in as far as the infrastructure is concerned. Most county hospitals are doing very badly in as far as structural support is concerned. Commodity support and equipment, I've talked about that, and again, supervision. The most common perceived patient barriers are lack of knowledge at 57%. So how knowledgeable is our population in as far as our cancers are concerned? Waiting time. The complaining, there's a long waiting time. Okay? Patient comes to Kenyatta. Some patients come to Kenyatta as early as 5 a.m. Then they are seen at 1 p.m. And they're supposed to go back to Kitui. They have traveled overnight, have come very early, but they have stayed for so long. Do you expect that patient to come back again in the next visit? If they are doing any better, they will not come. Discomfort with the male provider, about 2%. Fear of pain with the speculum examination, about 26%. Stigma, 19%. And then distance from the facility, that's long, about 17%. So what are some of the cancer pathways that make us very keen on primary health care? So if you look at the cancer pathway, and these are a generic pathway that has been presented. From the time there are some modifiable factors in terms of lifestyle, screening, perceived symptoms, predictive symptoms, but there's a point at which once you reach, then you have no control over. So the point is, our role actually should focus a lot more on that area below that oval shape. Above that, there's very little you can do in as far as cancer is concerned. So what do we need to do? What are the opportunities we have there? In terms of providing basic health services for all, first level of the community's contact with the health services, that's primary health care, ensuring early diagnosis and referral to palliative care, strengthening primary care providers' role in as far as health promotion, cancer programs, and follow-up of cancer patients for oncological reviews. Very critical. That clinical officer, that nurse in a district hospital, in a county hospital for that matter, do they know some of the early warning indicators in as far as cancer is concerned? Delivery of better quality primary care services, equitable services, and an avenue to achieving universal health care. I have just two or three more slides to go. Public partnerships in cancer care, what are some of the opportunities that we have to convene? Okay, that we are doing today. We have to convene. And once we convene, we have to integrate the services. Once we integrate services, we must catalyze an action and be advocates. Or rather, we advocate for patient rights. So organizations, the situation currently is that organizations often work independently from another because of geographic separation, sector isolation, because we have government, private, NGO, FBO groups. All these guys are very fragmented, if you asked me. We are working in a very fragmented sector in Kenya, and we must be very deliberate as far as bringing these people together. And objective differentiation. Some of them are research-based, some of them are training, some of them are screening, some of them are treatment. So we work in silos, and for PPP to work, we must integrate our service. The private sector not only provides capital, but also private sector know-how. Public-private partnerships are not about privatization, but about how governments can partner with the private sector to fill a gap. In this case, to help provide cancer patients with access to quality cancer services, for that matter. That's the understanding. It's not about privatization. It's not about government taking over Nairobi Hospital or MP Shah Hospital. It's about collaboration and integrating our services and complementing our services, for that matter. The government continues to provide stewardship, policies, and a conducive environment for service provision. So Eswatini once said that avoid erecting economic or political boundaries, and for us to be able to promote healthy partnerships. That's the framework that public-private partnerships work in. We have the government and multilateral agencies, civil societies and NGOs, for-profit institutions. All these come together, coalesce together, and form a primary public-private partnership orchestrated by companies, because we must have someone to be able to deliver on this mandate. Some of the calls for action actually are doing the robust internal assessments, measures of epidemiological indicators, external diagnostic surveys of adequacy of infrastructure, work process and user satisfaction, adherence to quality standards towards primary health care, embrace technology, talked about that, and lastly, feedback loops. There was some time we had a discussion on our gynecological wall, and the discussion was this either was a medical officer or a family physician in some part of this country who keeps on misdiagnosing patients. By the time they reach here, I think Dr. Maranga Mkombe, you remember that discussion, and the individual is known. Then I was asking myself, what are you doing about it? What are you doing about it? We know the person, we know they delay in terms of referral, we know they delay in terms of diagnostics, we know even the individuals for them, for heaven's sake. But what are we doing about it? Are we giving that feedback to them? Do they know what they are doing is harmful to the patient? And then which entities do you have in this country that can go and enforce some of this? So feedback loops are very important. And I'm glad some of the feedback has come in today in terms of diagnostics. How do you write a lab request? How do you write patient summaries? And how do you manage to do that? So very lastly is just again going back to primary healthcare and asking ourselves, what do we need to do? And I'll read for you two quotes here. Because of its work closer to health system users, primary healthcare can catalyze screening procedures, promoting early detection, increasing treatment possibilities, and improving patient quality of life. And that's the essence of us being doctors, improving patient quality of life, for that matter. If people have access to primary healthcare and referral systems, then cancer can be detected early, treated effectively, and cured. Cancer should not be a death sentence for anyone, anywhere in this world. Thank you.
Yeah. Dr. Chris Baraza, we shall give you admission rights immediately. Because, you really delivered as a guest lecturer. We really appreciate you. And I can see the journey you've had for you to be who you are today, including going to Antwerp, going to Uganda, going to many other universities. It is well worth it, Daktari, and I really appreciate you. So let's give Dr. Chris Baraza an extra round of applause. We have learnt about problems politics and policies, and you have really come together and explained to us what is necessary, both in the public as well as private and faith-based. So thank you very much, Dr. Baraza. When the form comes for application, I'll sign with the, I'll just close my eyes, and Odede will support me. Thank you, Asante Sana. That's our guest lecturer for today, Dr. Chris Baraza. Thank you. So moving on swiftly, we have a very special person in the room. He is a consultant trauma and orthopedic surgeon and specialized in revision of hips, knees, arthroplasty. He's a member of the Royal College of Surgeons in Ireland and fellow of the Royal College of Surgeons in England, trauma and orthopedic surgery. Health management consultant as well, with a master's degree from Harvard, no less, Harvard. He's an entrepreneur with a master's of business administration from Regent Business School. His interests are in healthcare, horticulture, real estate, foods, restaurant business. He is a recipient of the Order of the Grand Warrior of Kenya from His Excellency, our past President Uhuru Kenyatta. He is currently our Director, Medical Services and Research. Mr. Samuel Odede, karibu sana for your remarks.
Good morning, ladies and gentlemen. I'm shy. I don't know where that introduction came from, but honestly, thank you very much. Samuel Odede, my name. I think it should be coming in shortly. Senior management team, there's principal of the College of Health Sciences, Dr. Margaret Serima, I don't know whether she's here, also supported this from the very beginning. The rest of the TNH fraternity, ladies and gentlemen, and those joining us online, it's my distinct pleasure to welcome you to the 17th Reproductive Health Symposium. Hard work, culmination of work from the committee and from my office and from all the other auxiliary offices supporting it. Background. As we continue to get a foothold into the later decades, 5th, 6th, 7th decades, unfortunately, not just in reproductive health, in all fields, including mine, cancers begin to rear their ugly heads, and they will continue unabated unless we come up with proactive measures to either early diagnose, prevent. Somebody had mentioned, somebody had mentioned, you know, what are the factors that are causing a surge in these cancers. We mitigate the short, mid, long-term effects of these cancers, and it's against that backdrop that we have this great meeting of minds to discuss, in particular, reproductive health cancers. Now, cancers, and especially RH, reproductive health cancers, continue to cast a long and ominous shadow in the health spectrum of this country. However, it's been met by steadfast resolution, just like this, to ensure we all fealty to the ethos of the universal healthcare, to ensure equity as far as the planks of the Sustainable Development Goals apply. Equity in health, and in particular, equity in the girl child. I know reproductive health is not necessarily only girls, ladies, but the thrust of this and what we've had thus far, almost entirely, 100%, ladies. As a saying that says, educate a lady and you educate the world. I believe I can paraphrase it and also mention health. Address it, and we will enlighten the world. Again, I'm an orthopod, so forgive these statistics if I'm a little bit off. About 1 in 6 ladies will encounter some form of reproductive health cancer, one of the benign malignant. which represents roughly 17% lifetime risk. Now that's an inordinately high amount. Add to that treacherous cauldron, add poverty, lack of accessibility of efficient, effective, ethical, accessible healthcare. I think Dr. Baraza mentioned somebody from Turkana died while awaiting the results to come. That is inexcusable in the 21st century. Add to gender-based violence, risk, lack of adopting risk-averse behaviors, etc., and we are faced with a bleak future. And that's why symposia like this, the importance and the urgency of this cannot be understated. Here we get an opportunity to shine a spotlight on our successes, also our failures, celebrate our successes, learn from our failures, adopt evidence-based practices spurred on by research, etc., etc. So I'm glad that we have a meeting of minds here to resolve this issue. Now, from the Director of Medical Director's Office, we will have to be, not just be seen that we have them, but we have to be seen to be adopting them, and we'll have to adopt them. So rest assured it will be adopted. Meeting declared opened. Thank you very much.
Thank you very much, Mr. Samuel Odede, our Director of Medical Services, who has also taken the opportunity to represent our Chief have received from the management. We have recently received approval to participate in what is ultimately going to translate into FDA clinical trials. And we are beginning the trainings for that during the course of this week. So I also want to express gratitude for the immense support that we have received from the DMSR and from the Chief Executive Officer's office in the process of pursuing this important venture. So we are actually marking a very big milestone in the Nairobi Hospital this week as we celebrate the accomplishment of this symposium. So with that, we are also grateful for this meeting having been officially declared open, and we wish to express our gratitude for this. as we break briefly for a cup of tea. Yes, I think we'll take about 15 minutes so that we can also redeem time. We have quite a number of excellent and riveting presentations that will be before us. So we have a very lovely menu that is being set before us by our excellent panel of esteemed and highly established specialists in gynecological oncology. And to boot, we also have the opportunity to listen to a cancer survivor. And later on, we will also have the opportunity to receive some guidance on legal input regarding the management of cancers from a sociological perspective. So please don't touch that dial. Please remain, stay tuned, and join us for a cup of tea. Thank you very much.
of it. Sir James Nyamongo is holder of I think finance, bachelor finance degree, an MBA, an MSc in production, and is also a recipient of the Moran of the Burning Spear from the previous president, Mr. Uhuru Kenyatta. Mr. Nyamongo was very instrumental in the success of this, and in all his meetings, and especially the board meetings, is very strident that anything to do with exchange of knowledge and research should be brought to the fore, and he's empowered my department fully to do this. Even when it's not budgeted for, he will wiggle his way to find a way of getting it done. So we have a stalwart in Mr. Nyamongo.
Since I'm not a medic, I've spent my life, most of my life in each sector. That's why I'm an expert. But I'll try as much as possible to conform to what you require. First, I want to take this opportunity to thank the organizers of this symposium this morning. And I'm sorry that I came a bit late, but it's late, never late, come late, but never come in. So first, I want to thank the chairman and members of the Nairobi Reproductive Health Symposium Committee, which has organized this particular symposium. The directors and the senior management of the Nairobi Ostro, our accomplished speakers who are present, distinguished guests who have been invited, ladies and gentlemen. Good morning. As the chief executive of the Nairobi Ostro, it is my earnest wish to welcome you to the 17th Annual Reproductive Health Symposium. The theme of this year's edition, as I'm told from the organizers, is Reproductive Health Cancer, Time for Action. This is a very timely theme for this year, as there is an ongoing outbreak of cancer as a whole. Given the fact that women of reproductive age represent a big number, proportion for both and the overall population and the population of those who are capable of working and earning to build our economy. Addressing the problem of female reproductive cancer will significantly reduce the overall cancer burden. This could result in improvement in the outcome of patients and has the potential to reduce and revise the current unacceptable high cancer rates in Kenya and beyond. As participants of this is something which probably part of you have witnessed, and cancer actually has become one of the biggest killer diseases in this country. And as experts, we need to really focus and see the means and ways how we can reduce this menace. And by exchanging ideas in a symposium like this one, you are able now to get some more ideas and probably see how we can counter this. As an institution, one of the things probably going through our strategic plan, which was a bit delayed, late, and we started implementing in 2021 instead of 2019. This was has been delayed because of the governance issues which we have been affecting our institutions. But as head of management of these institutions, I have been very focused on this area. And we have had discussions at various levels and at the board level. And one of the areas which I'm focusing on right now is to ensure that we have proper equipment which should be addressing this particular aspect of the disease so that we can be able to diagnose this disease at an earlier stage. And as I stand here this morning, we have got a grant of about 140 million from UCIDA. And this specifically will be or installed the PET scan in this institution. So, and then the second one is to have 5 more developed units going outside. And the other area is on the improvement of ICT. This is a grant, unconditional grant. It is not having any conditions attached to it. We have been spearheading the negotiation from last year, July, and we signed the agreement with the American government on 21st of last month. When I traveled to Nairobi with my board chairman, we signed for the grant. So we will be going out on this when we are doing the feasibility study. And my focus is to install a PET scan in these institutions. That is my wife. And by doing that one, we are also now looking at, after this, the feasibility study, and you will be having questionnaires which we will be forwarding to you, and mostly the cancer area through the medical directors research. We will be able now to get data, and then we think how are we going to finance this one. My prayer is that in the next 2 years or 1 year or so, because they wanted us the study to take about 3 years, I've said no, and we have come to 6 months. So by November, we could be on the right foot by having now a concrete answer where are we going to put the PET scan equipment to diagnose cancer at the earlier stage. We have also factored the health burden of cancer in our overall strategy, as I said, to improve the healthcare services provision of Kenya. Along this line, we have established the Nairobi Hospital Cancer Center, which is in line with our 2019-2024 strategy plan. It's our enabling our hospital to shine as a beacon of excellency in the cancer care in Kenya and beyond. At the Nairobi Hospital Cancer Center, we have pioneered the provision of biotherapy for prostate cancer, a substantial reproductive cancer among the main globally. We have also become a local authority and a reference point in the provision of chemotherapy, surgical therapy. That we are able to provide those services. This is an excellent evidence of the English adage that states that a stitch in time saves 9. After all, the outcome we are seeing from the excellent qualities of care we are offering is objective evidence that we are making a positive difference in lives of our patients, their families, and thus the society at large. I therefore wish to congratulate the Nairobi Hospital Cancer Center and the affiliate consultants for the marvelous strides that they are making in this vital area. The collective dedication of this team of experts, researchers, healthcare professionals is evidence of their indefatigable striving to improve lives of those afflicted and affected by the cancer menace. However, as a society, we are in need of embracing an even more comprehensive approach that encompasses prevention, earlier detection, thromboid earlier treatment, and compassionate care. Today, as we gather for this symposium, we acknowledge the immense potential for the progress and collaborations. In this event, we have experts from diverse disciplines, who have devoted their lives and career to combating gynecological cancer. Together, we possess the power to make a real difference, not only in the lives of individual patients, but shaping the landscape of women health care as a whole. Ladies and gentlemen, as I conclude my remark, I wish to express my utmost appreciation and support to the brave women who have battled gynecological cancer and to their families that they have stood by their side. You are the inspiration behind this work, and it is with you in your hearts that we strive for progress. Let us embrace the Symposium as an opportunity to forge a new alliance, challenge boundaries, and chart a course towards a future where gynecological cancer are no longer a cause for fear, but a challenge that we have conquered together. Together, with the Nairobi Hospital's Cancer Center at the forefront, we will continue to rise as a center of excellence in cancer care, not only in Kenya, but as a beacon of hope for the world. And with these few remarks, I wish you a fruitful day as I declare this symposium officially open. Thank you. I will urge the participants in this symposium, let us develop a positive mind. Let us not thrive in negativity that one of the challenges which is confronting us as a cancer can defeat us. Let us be strong. And I challenge you to offer you your professional ideas and ensure that probably we have made a stride forward and we are able to do more than what we are supposed to be doing right now. As we implement the strategic plan, let us actualize. Let us move forward. And I urge you, if there is any situation as we start now, the speed study, my door is open and I'm open to ideas how we can improve our cancer center to be able to provide more services to Kenyans and beyond this boundary. Thank you so much.
Last time we had our first symposium where after COVID, I was with Mr. James Nyamunga. He had just come in and he was literally there to open the symposium. Thank you very much. And this is a journey we are all together, and we want to make it great and also great for the Nairobi Hospital. Now, as we proceed, I would like to invite our speaker this morning. Our speaker is somebody who probably I feel very, I am not qualified to introduce him because he's been my teacher, he's been my mentor, he has done a lot in the area of cancer. All these programs you are hearing about cancer, he has always had a hand. In terms of introduction, I think Professor Ojwang is somebody of starting a program at the Nairobi Hospital, and I'm quite happy that most of the speakers this morning have also passed through him, and he was instrumental in steering that. And I'm sure he'll be very instrumental in also helping Nairobi Hospital to achieve its goals. Now, if I'm to introduce Professor Ojwang, I think we need probably a week for me to go through everything, and we may not have time. So having said that, Professor Ojwang is going to take us through introduction of gyne-oncology. He has been there from the beginning. So the topic we had given him is, of course, this is the Reproductive Health Symposium. Cancer, reproductive health cancer, time for action. We've always been talking. But as we have seen from previous speakers, action also has to come. So time is now, and we wanted him to speak how cancer and cancer care has evolved over time, and we think he's the best person to give that presentation. So could we please welcome Professor Ojwang to give his remark. He said he's also going to give a paper. Thank you very much. Welcome, Prof. Ojwang.
Thank you. Thank you. Myself, I don't have what to introduce, like these things which are being given by Kenyatta. But I can assure you that though I don't have them, I've had the privilege of President Kenyatta staying next to my home for 3 days, and nobody knew. I'm not the one who invited him, but he found the place so nice that he decided to stay there, just half a kilometer from my home in the rural, for 3 days. Anyway, thank you for giving me this chance. What I'm going to do is to talk about introduction to gynecological oncology. I've seen gynecological oncology involved in this country. In fact, I was the one who introduced this terminology, oncology, in Kenya here, in early 1972. And nobody knew about it. I went to the CEO of Kenyatta National Hospital at that time and told him, I would like to start treating this cancer. I want some chemotherapeutic drugs to use. And you know what he told me? Why do you want to treat these people who are dying anyway? Yeah? I told him, no. They are not dying. It's just they are dying because we don't have a way to treat them. And we started by ordering melphalan. I don't know whether any of you know melphalan. We used to order it from England. It used to be flown here. And eventually we found that actually it was not a very good drug to use for cancer of the ovaries, because eventually some of them developed leukemia. Yeah? So we started a long way ago. Can you come and show me how to? I left my computer. Which one? This one? This forward, and this back. So, when I saw the invitation, there was this topic, time for action. Yeah? I think this one should have been the last, but there it is. It was the first one, time for action. I believe that it has always been time for action. Only people didn't really think that cancer is a major problem. I remember when we started seriously think about all sorts of gynecological cancers in Kenya here, people didn't like us to talk about them. Yeah? We started with Kasili, the late Kasili. The late Kasili created a pediatric ward in Kenyatta Hospital. I created gynecological cancer ward in Kenyatta National Hospital. And we had lots of problems. People came from pediatric side, said, this Kasili was a hematologist, right? How can a hematologist treat children? Yeah? And then they came to me and told me, cancer is not a priority in Kenya. We don't even need a specialist in cancer. Yeah, we better have general gynecologists, and that's will be better than having people building their own castles in Kenyatta National Hospital. So you can see where we started. So the time for action, action, it has always been there. Only that we didn't have enough people to all support for us to go on. Yeah. what is there is the definition of gynecological oncology. It's an area of medicine which deal with study and treatment of cancer. Yeah, that's what it is. And it involves treatment of cancers of the vulva, cancers of the cervix, vagina, uterus, and fallopian tubes and ovaries. That's what it is. And I think I'm not going to waste time going through all this in details because you have had presentations already. If you look at what global cancer has found, yeah, Africa has the largest number of this, especially cervical cancer. If you look at cervical cancer, for example, you find that something is interesting there. 20 years ago, South Africa was better than us in detecting cancer of the cervix. But according to global cancer, right now, Kenya is better than South Africa in detecting cervical cancer. Why is it so? Why is it so? It's because of what health workers have managed to do. Yeah? More patients are coming to the hospital. More doctors are doing clinical examination. They are doing pap smear and all that. If you know South Africa, it's a skewed sort of society. If you go to Cape Town, for example, you find that the whites are better off. But you go out of Cape Town, go out of Johannesburg, and you'll find that actually those people are living poorer than the poorest people in Kenya here. So when they started saying that, okay, they are better in South Africa, it was in Cape Town and it was in Johannesburg. But because of the work we have done during the years, we are better off in detection than them right now. In fact, to tell you the truth, you have heard of HPV. Kenya was very instrumental in study on HPV. Yeah? In fact, the tissue from Kenyatta Hospital was the one they used to actually detect HPV. So in other words, there are many areas we are doing very well, in fact. I'm not going to go in details, but cancer of the vulva, for example, account for 5 to 8% of all female genital tract cancers. Yeah? But this cancer of the vulva, why should it come so late when the area which is involved is actually quite an accessible area? Why? Why should it be like that? And those are the things we need to ask. Yeah? For example, that one is a very advanced cancer of the cervix. Yeah? Why should it be like that? One, education is lacking, yeah, amongst our people. Secondly, it's a private area for most people. So even if they are sick there, they don't want anybody to look. Also health workers, yeah? Health workers. Sometimes health workers are the culprits. I have heard in my office, for example, a gynecologist looking after a patient with cancer of the cervix, or the vulva, and only giving some oil to put there for 6 months, not worrying that this patient might have cancer of the, not even taking a biopsy. I know the gynecologist, I'm not going to mention the name, but I know him very well. Yeah? So again, this question of referral, people should refer, doctors should refer patients, nurses should refer patients, clinical officers should refer patients. Yeah? Sometimes patients are not referred from doctors simply because the doctor wants to have a say in the management of the patient because of financial reasons. And this one, we have been discussing this many times even in Nairobi Tumor Board. Keeping patient because a doctor wants a little bit of money from that patient. Yeah? If we avoid this sort of way of looking at this problem, maybe we are going to be better off. As I said, that's very advanced cancer of the vulva. Why should cancer of the vulva be advanced like that? And believe me or not, yeah, I've had patients with very advanced cancer like this, and they are still having sexual relationship with the husband. Can you believe that? Yeah? And they just come because they are bleeding. You look there, you find there's a cancer like this. Yeah? What about malignant ovarian tumors? Yeah? Cancer of the ovaries. You know that this patient come rather late because ovarian cancer somehow is a very slow and serious growing tumor. Yeah? It grows and the patient just thinks, okay, I'm pregnant or my tummy is getting big, I'm just getting fat, and yet she has ovarian cancer. Just imagine, just 1 in every 56 women will develop the disease in their lifetime. So it's not a very uncommon disease. They only come late because the disease presents very late. By the time they come to see you, you already have stage 4 of ovarian cancer. Endometrial cancer, we have talked in details about endometrial cancer. Just know that if you get it late, then you have lost your patient. Especially if you get it in stage 3 and 4, you have lost your patient. There's nothing you are going to do to help that patient. Because so long as this cancer is in the uterus, it will stay there for a very long time, in fact, for years even. But once it perforates the uterus, that's the end of it. It grows so fast that you will not be able to stop it. Choriocarcinoma, this was what was being treated in Kenyatta Hospital a long time ago. This is the only cancer they knew could be treated. Yeah? But only one drug was used, for example. Methotrexate is what they used to use. But now we have managed to introduce other drugs, and therefore the treatment is much better than what it used to be a long time ago. What are the modalities of which we need to improve on for treating ovarian cancer? Surgery. I mean, surgery, though I would like to say that surgery is a very poor method of removing cancer cells, and you know the reason why. You only remove what you see. What you don't see, you don't remove. By the time you cut it out, you have left so many other cells in the area. Yeah? So you need another thing to be able to treat these cases. Long ago, let's say 1970s, surgery was done mainly by gynecologists. Yeah? It was done mainly by gynecologists, and therefore they did only early cases up to stage. Actually, they didn't do stage 2. They ended up stage 1B. Yeah, only the other patients were sent home to die. Yeah, they were sent home to die. But now we have radiotherapy as well. Radiotherapy started in Kenya here around 1970s and improved the treatment a little bit, yeah, for those who could not have surgery. Again, for surgery, you need a lot of training. Not any gynecologist can actually do these surgeries. But even now, as I'm talking, there are many gynecologists who actually don't refer their patients to gynecological oncologists. Again, because of money. They want to keep the money. So they don't refer patients. If I'm wrong, you just tell me I'm wrong. But I know I'm right because I've treated quite a number of patients who have been mistreated outside there. Yeah? So surgery is a very important method of treatment. It's there, but know that it's a very poor method of removing cancer cells. Then radiotherapy was introduced, as I told you, early 1970s, late 1970s, no, early 1970s, and it has played an important role in managing cancers, gynecological cancers. What has it done? We used to stage patients, stage 1, 2, 3, and 4, but we found that this patient at stage 4, then the patient was sent home because there was no place for them in the radiotherapy department. They were so advanced. But know that with the radiotherapy, you can actually treat all patients with cancer, even stage 4. I've had patients with stage 4 treated and they are living 20 years after treatment. So don't send those patients away as we used to do that before. We have external radiation. I'm not a radiotherapist, but I have gone through it through my training. In fact, when I came from training, I was actually the one treating all these cancers, giving radiation to all these gynecological cancers. Yeah? But as we trained more radiotherapists, I stopped it because I was getting a lot of radiation myself. Brachytherapy, we have that in Nairobi Hospital here. And I can assure you that if you give external radiation alone to patients with cervical cancer, you are not going to treat that patient because the dose distribution is very erratic. Yeah? So you are not going to treat that patient properly. You have to give brachytherapy or intracavitary treatment for the patient to get cured. In fact, we used to use very crude method of giving brachytherapy. I'm the one who introduced it in Kenyatta Hospital. It was very, very crude. It was manual loading. Yeah? So you get a lot of radiation out of it. But now we have brachytherapy, and I don't even go to cancer center because it's a very easy thing to do. Even those who are radiotherapists, they can actually insert this thing themselves. Chemotherapy also has evolved quite a bit. Yeah? We have quite a number of drugs. Those who attend cancer tumor board on Thursdays will know that. There are so many drugs which you can use, and we are better off than what we used to be in 1970s. Combination of both is important sometimes, and palliative treatment is also important. One day I was listening to a lecture, and somebody was presenting on cancer management. And he mentioned all sorts of treatment. But at the end of the day, he said, no, I've reached the end. There's no evidence of any method of treatment which can be used on this patient. And then I stood up and asked her, but evidence, thinking is what produces evidence. Has somebody stopped you from thinking? Has somebody stopped you from thinking? And that's something I would ask here. If you have no evidence, do you stop treating the patient? Can you put your hand up? If you don't have evidence, then you stop treating the patient. Put your hand up. Yeah? Thinking is what creates evidence. Evidence does not create thinking. Okay? And therefore, myself, I say, I like to live at the periphery of science. I don't live in the middle of science where evidence is. Because if I say I'm going to live in the middle where evidence is, then I'm not going to produce anything. I'm not going to produce any new thing. And I can assure you, in my lifetime, because I stay at the periphery of science most of the time, I've introduced quite a lot of things in our medical system which are being used up to today. Yeah? Nairobi Hospital, when I was introducing treatment of eclampsia, or preeclampsia. People shouted at me, that what are you doing? Why are you introducing this thing in Nairobi Hospital? But since I was staying in the periphery of science, I said it will work. Think, and it's being used in Nairobi Hospital today, the way eclampsia is being managed. And that's what we started, even in Kenyatta Hospital. People shouted at me. In fact, when I went to the pharmacy to try and get the drugs we use for treating eclampsia, the guy told me, no, the pharmacist, we are not giving you this drug. Then I told him, you want 10%, that's why you are saying you are not giving me the drug. But eventually I convinced him, and he gave me drugs to treat patients. Simple things, simple things. What is being used, for example, sorry, I'm going out of this a little bit. What is being used outside there to determine the size of the baby if you don't have anything? Yeah? The gap, circumference, measurements. Because of living out in the periphery, I introduced that, and it's being used all over the place now. Yeah? It's even gone into books. There are quite a number of things which you can introduce, actually, if you don't go out of the periphery of science. So, for those who believe that if there's no evidence, you don't treat a patient, what about palliation? Is that not treatment? Palliation, palliative treatment, is a treatment. In fact, we had a problem with these patients, myself and the late Professor Kasili, that we started the hospices. You know hospices in the Kenyatta Hospital. We started it behind the casualty in some tin house. Yeah? It has grown and grown and grown. They don't know who started it now. Yeah? People are getting PhDs in that area. Okay? But we started it, the two of us. It has grown out of Kenya, it has grown out into the rest of Africa. Yeah? Palliation is just treatment. Unless somebody does not think, then he stops with evidence-based and doesn't do any palliation, just tell the patient to go and die. Now, treatment for cancer in women is a multidisciplinary approach thing. Yeah? You can't treat them alone. You can't treat them. You see all those people are listed there. You need a general gynecologist. The general, I thought I was, okay. We need a general gynecologist. We need a pathologist. We need a cytologist. In fact, a cytologist is very important for you to diagnose, for prevention. I happen to be a cytologist as well, though I don't use it. Yeah? Radiologist. Yeah? We want to have a PET scan. Radiologists will use it. But it is nuclear medicine. Yeah? So you need nuclear medicine specialists as well. Psychologists to work on the way the patient thinks. Social workers, nutritionists, and the family, of course. Family practitioner. Yeah? And then you have the radiotherapists, medical oncologists, tumor board, we always argue with Abinya about these things. Yeah? Urologists. In fact, you need to have nurses, nurse oncologists, for you to achieve what you want to achieve. So, what is the change which has occurred in Kenya during the last few years? The most important to me is the training of gynecological oncologists, which people didn't want us to do for a long, long time. People did not want us to do that. But eventually we managed after so many years of struggle, to train gynecological oncologists. Can you stand those who are gynecological oncologists here? Blow your own trumpet. Nobody will blow it for you. The others are not here. There are quite a number of them. We just produced them 2 years ago. Yeah? And I was John crying on top of the mountain. We produced 8 of them. Yeah? And we are going to produce another 8. And after that, another 8. And let me tell you, within 3 years, 6 years, we'll have enough for Nairobi Hospital as well. Though some of these people work in Nairobi Hospital, I'm one of them, but we'll have many of them. It has been shown that patients with gynecologic cancers treated by trained gynecological oncologists have better survival compared to those treated by general gynecologists. And references are there. It's not something I'm thinking about myself. Therefore, please refer patients to gynecological oncologists if you can. Basic training, I can't read it very well here, but you can read it from the board. Yeah, because of time factor, just read what you need to go through as a gynecological oncologist. And those who are gynecological trained in Nairobi University, you can support me that you went through all these things. Yeah, you went through all of them. So nobody can say you don't have qualification here. Yeah. So, conclusion. Improve on prevention and early diagnosis. In other words, education is very important so that women know that they should go for checkup, pap smears, and all that. Yeah? Primary prevention. Improve on diagnosis. Yeah? How are we improving on diagnosis? We are trying to train medical workers to be able to diagnose these things very early, even if they are not gynecological oncologists, right? And further, we are trying to train more gynecological oncologists so that we improve on detection. Treatment facilities. I can assure you there's been a lot of change on treatment facilities. We have a whole center for gynecological oncology. I personally, initially I was not very much for the size, yeah, because I didn't think we'll get enough patients to occupy 66 beds, which are there, yeah. But anyway, we had it, and it's working. Sometimes we use those beds for other patients from other areas, yeah. But that is a big improvement for Nairobi Hospital. Training of personnel. Not only the gynecological oncologist, but we need to train nurse oncologists, or not just nurse gynecological oncologists, but nurse oncologists, yeah, who know what to do with these patients. Then we should think about teamwork, and I showed you what type of people should be in that teamwork. As an individual, we won't go very far, yeah, and that's why we have sometimes tumor board, so that we can discuss how to manage these patients. Vaccination, for example, cancer of the cervix. It's a pity that it is not doing as well as we want it to do, yeah? Because actually, I helped the ministry to get the first vaccines for this country. But now when I told them, okay, I got you vaccine and you are using it in Machakos and those areas, and I don't know what you are using it for. You tell me at least what you are using. And you know what they told me? Oh, the Ministry of Health has taken it, now it's out of you. Yeah? So I kept quiet, right? But believe me that Kenya was part and parcel of detecting HPV virus. I was involved in that with my German colleagues. I think I'll end there. My time is over, and I hope that with so many of us now interested in cervical cancer, we'll get more people to come for training. Yeah, I can assure you I'm the oldest now in the University of Nairobi medical school now, because for a long time they didn't want me to go away from the medical school because I was training these guys on cervical cancer. But now I'm cooling down a little bit. Thank you very much.
Thank you very much, Prof. Juang. And I think another big applause of hands. Thank you.
school, they decided that diagnose it and treat it. Yeah? So maybe we should slowly by slowly, normally I like to do things slowly sometimes, try to sensitize people and eventually take over and start doing breast surgery as well.
It's rightly said by you, and the question which
Kango, yeah? This is a Luo elder, yeah? And let me tell you, he made the location where I come from, the seat of academia. In Kenya, yeah, not only there, yeah? And they retire, they don't retire very much. So I don't think there's a time I'm going to retire, I'm just going to die. When
to share more of his experience and tell you how he has survived with that cancer and probably the challenges. And I'm quite honored to introduce Washington Kimani, who is a cancer survivor. And he might want to share his experience. I think in this forum, we also need to also see reality and hear reality as well. So as we wait for the other, for the Professor M to give her talk, I would like to invite Washington Kimani, please. And Dr. Moledina, who is going probably to navigate him in areas probably to explain one or two things. So Mr. Washington Kimani, please, maybe you could have a seat. Yeah, you could just feel comfortable, have a seat, you can share your experience. Moledina, if you want to sit next. You can get the microphone, please. You can give the microphone. The microphone is there. Yeah. Okay.
Ladies and gentlemen, it is my pleasure to introduce Mr. Washington Kimani, who first came to my clinic tragedy he went through and how he survived, how I came into picture, and rest of the thing let him introduce, I mean himself, as well as how he has gone through this.
Good afternoon, everyone. As
Afternoon.
you have heard, my name is Washington Kimani, and it's been an honor to be with you guys. I've never been in such a forum, but I'm happy because this is my old man. I call him my old man. He has been there on my journey. As he has said, first of all, I didn't know what was happening with me. Took him to realize that my testes were not functioning. Then later on, I had to do a few tests where I was diagnosed with leukemia, that is blood cancer. The news were not that good, because I think by that time, my wife also. I think, as I told Dr. Arya, she had left. So, because now, you see now, you guys cannot have a baby. Yeah, nothing will work on that one. So, on that case, Dr. Moredina recommended me to do a bone marrow transplant, which I was able to connect with family members and also a few friends. I went to India for like 1 year. That's where I did my bone marrow transplant. And since then, it has been a journey all through. For my bone marrow transplant, has a lot of challenges. Let's say, for instance, because of you guys are in medical field, you know how GVHD occurs after the transplant. That is graft versus the host disease, where we normally have now the skin. Early last year, I had lost my eyes. I could not see because of the cataracts. But unfortunately, after 2-3 months, they came back again. I lost also my weight. My reproduction was not functioning also. So through assistance of Dr. Moredina, he took me to a few sessions where I've been now doing his follow-up. And things are looking good now. So at least I'm happy, and I'm glad to say I'm a survivor.
And if you have any suggestions. Okay, I want to ask him a few questions. How cancer affected your family and yourself?
It was not quite good news. As we all know, good health is always the best thing. One day you wake up, then you go to the hospital, you're like, you have to do this test and this also. Okay, what is happening? Then the doctor says you know what? Something's not working well on your body. So those news, once you come to share with the family, everybody is like, oh, it's cancer. And in mentality, like in our society, all we know is that when someone has cancer, it's death sentence. Right? Or am I speaking to myself? It's true. Because
Yes.
I think you have come along cancer patients. Even when we are sharing, like, I had my sister there mention about the breast cancer. I have a relative who she's suffering from breast cancer, so she was like, okay, I am on the breast cancer. You went for leukemia. We are all fighting the same thing. Just that for my news, I didn't receive them positively. But you, through the way you have battled with your leukemia, I'm also willing to fight for my breast. And now she's okay. And like, she underwent the surgery. Now she's doing good. Her health is back. And I think we always have to give each and everyone hope for tomorrow, right?
What is the best change you saw after your recovery? And maybe you can tell about the center you have developed, so they also know about your center.
Okay, having stayed in India for almost 1 year and also going for some reviews, I thought of giving it back to the society, like, what can I do to my community? What can I do to other people? We started this center called Satyuk Healthcare Center, whereby in conjunction with local doctors and also Indian doctors, we are helping other patients, like for instance, who are suffering from the cancer like I, get to know the assistance where we can assist them from maybe the treatment in conjunction with the hospital. We have been doing something called giving them information. I have a few slides I will show you on that company, whereby Dr. Muredina organized something for us. You can show them the slide? Yeah.
He'll be showing you some of the slides and how he has achieved it, and it is very amazing. And I think it's a step forward for us also to learn from what he really deserves and he has gone through. And what advice you can give to others? Can you just enlighten, though you have shown everything and you have already spoken, but just few things that what advice you would give to a patient who is suffering from cancer or friends who are suffering, and what advice you would give to us also?
My best advice I can give you guys is, like, when you're treating us or the cancer patient, always try to give that person hope for tomorrow. Let us not see cancer as a death sentence. I know sometimes it comes whereby, for instance, if, like, I have walked that journey with Mr. Moredina, he has been there like a father, a friend, checking up on me. Maybe sometimes he even call me and like, hey, Washington, how are you doing? How are you feeling? It's giving me hope that somebody somewhere cares. And he's telling you, wake up. Tomorrow is a brighter day for you. Thank you.
Lastly, you see, you must be thinking that every time reproduction means ladies. No, here there is a gentleman. Yeah. So, gender equality. You can see he has represented himself, and this gives an idea that don't only bank on ladies about reproduction, it's both male and female.
Yeah, Moledina, thank you. Can I ask Washington a quick question? How old were you when the diagnosis was done? How long ago also?
That time I was around 30 years.
You're 30 years.
30 years. No. It's when I started now the early stages.
Right.
Where I didn't know whether I'm going to be diagnosed with cancer because I started losing weight.
Okay.
My body was a bit weak. Yeah, from that years.
Yes.
Right now I'm 36. So
Okay, and you are married at that time?
that time I was married.
You are married.
I was
Yeah.
married.
The reason I'm saying is because I don't know if I will call it a missed opportunity. These are the areas we are going to look at, because you could have benefited from maybe sperm preservation, if need be, and
Correct.
considering that you are married, it was much easier. You could even have gotten fertilization, or you keep those embryos with your partner. The issues of ovarian tissue preservation probably could have been challenged because of the blood-borne disease. You talked about leukemia, and I don't know how it will happen later on, but at least there are some areas you could have benefited from.
Correct.
So that's why when we discuss these things, we look back and we see things that could have been done. I just wanted to raise up that area a little bit.
Thank you.
But I'm sure still there's a lot that can still be explored.
Correct.
Thank you very much.
Correct. Thank you.
You also had leukemia.
Yes, correct.
Yes.
So what happened to it?
When I got in, this one, let me show you something.
Yes. Good.
Go back front again. No, the other one. On the first photo, this was me. Here it was leukemia stage 4. And I had 2 weeks to die. When I got into India, the doctor told me, you only have like 2 weeks. If you're not going to do the bone marrow transplant, these are not going to be okay. Now the second photo, this was me before now getting diagnosed with leukemia. Here I was suffering from whatever Dr. Moredina said, something to do with the testes. And that photo, if you look at that photo, it was now nearly after my wedding. It was nearly after my wedding. Then we go to the other one. So here is when I reached to India. So I was admitted. Then here, actually on that one, still I have 2 weeks, but I could afford a smile in the hospital. At least I had the hope of having like fighting it again. That was my father. I went there with my dad for like a year. Those are a few nurses. Then there's another one. You like one of them? They were quite friendly. They also did a birthday for me that time. This is when I was getting now the transplant. Now the worst thing happened. After the transplant, there is this thing that I've explained called the GVHD. That is my donor stem cell fighting my stem cell also. So it occurred that my skin had to develop this one, and also some pulses started coming from my back, whereby now I asked the doctor what was now the cause of this. He told me it is called GVHD, whereby my brother was the donor. So I think now his stem cells were trying to fight now against my stem cells. But after a few months, it came back. Now this one is the recovery stages. Here I had lost my eyes. I could only use now the sheets. People could not see. There's another one there. This now it's a health organization. I've started with the India's doctor, where we are trying to help other people, and also in conjunction with this one, we would like to interact with other medical hospitals to bring other doctors from India to come and assist our local doctors for training, free of charge.
Thank you very much, Washington. Thank you very much. Chesanam, we want...
First, the diagnosis was treated. It never mentioned.
On the first diagnosis, when Mr. Moredina, I went through how many months? Around 6 months through medication. Any other question?
The crowd is very happy and
thank you.
feeling excellent the way you have gone through and you have dealt with the
just examine the vulva and do some. I've said immunosuppression. And Northern European occupants tend to get it a lot. I cannot maybe explain. Epidemiology, I don't know whether it was covered in Maranga's case, but it looks like he must have covered epidemiology. It's only 6% of all gynecological malignancies and 1% of all cancers affecting female. Worldwide estimated to be around 45,240 women diagnosed with vulval cancer in 2020. Sub-Saharan countries, including Kenya, have raised numbers. Most of those patients who have the high risks I've just talked about 85% of HIV patients will be found to have, or about 85% of patients with vulval CA have HIV positive, and according to FIGO, they usually present in stage 2 and stage 3. That's our big challenge in terms of management. In terms of follow-up, survival rates are also good if we catch them early. For 1 year, they are about 80%, and survival rate for after 2 years drops to 51%. Clinical presentation, usually they present with vulval lesions. It could be a lump, it could be an ulcer, it could be just a raised nodule, and also pruritus vulva, especially in the older women. Other presentations include vulval bleeding, pain, dysuria, constipation, rectal bleeding if the tumor has extended to the rectum. Enlarged lymph nodes may be found in the groin, and the lower extremities tend to get swollen, especially when the nodes are involved. In terms of prevention, primary prevention is avoiding any factor which precipitates, or all the risk factors we've mentioned. One has to up the hygiene in the vulva, and also be vigilant about anything which presents in terms of what we have said. Avoid smoking, because nicotine will be found in cells, biopsy cells, phenols, and also talcum powder, which tar is a culprit. Like you see in the scrotum, where you find the locomotive drivers tend to get scrotal cancer. This is the same thing with the women. If the woman is encouraged to take high vitamin C, it's an antioxidant and immune booster, which kind of is protective. Secondary prevention include early detection and treatment of vulval lesions. Low seal and both eye seal, they could present as condylomata, and this is reflected by the fact that they do present just the way we have HPV in cervical cancer. They also get vulval intraepithelial neoplasia, and this needs to be treated early. In terms of treatment, we should proceed. This is more of precancerous lesions I'm talking about, whereby you can actually proceed and treat by excising the area which is affected using a colposcope. Hardly do we see those patients in our setup. They do come very late, and that's when we catch them. And a few of them who come with obvious leukoplakic lesions, when we do biopsies, we may be lucky to diagnose, and that will be just a simple, it will be wide excision if it has not gone deep, and that is quite sufficient. Unfortunately, we don't have a routine screening method for vulval squamous intraepithelial or carcinoma, for that matter. Cervical cancer, I don't want to belabor on the introduction only. Maybe we can say that human papillomavirus is central to the development of cervical neoplasia and can be detected in 99.7% of cervical cancers. The most common histological type of cervical cancers are squamous, followed by adenocarcinomas, which are 25%. It's common among women worldwide. Most of them occur in poor resource areas, especially in the third world. As far as epidemiology is concerned, I was told Maranga covered it. Let me not go through it again. Risk factors of cervical cancer include the following: early onset of sexual debut, multiple sexual partners. This is a lifestyle, actually. A high-risk sexual partner, and most of those things are associated with HPV. History of sexually transmitted infections, chlamydia, early age at first intercourse, and also increasing parity. History of vulval or vaginal squamous cell intraepithelial neoplasia or cancer is a risk factor. This is created by the fact that we have what we call field defect. The HPV virus, when it affects the cervix, it does not limit itself. It will spread to the vagina. It will affect other places, even the throat, for those who practice oral sex. And so these are the places which one has to look for this problem when it arises. Non-HPV related ones are usually associated with low socioeconomic status, oral contraceptive use, cigarette smoking, genetics, and spouse of uncircumcised male. Although circumcision does not completely get rid of the risk, because there are other factors. How do we then prevent cervical cancer? Delaying all those or reversing all those risk factors is very protective in terms of our social behaviors, and also avoiding people who may be at risk. Another aspect we need to approach is advocacy. We need to talk about it. We need to go to the social media, go to vernacular station, and educate people on what cancer is all about, and that it's not a death sentence. And this is something which I think is very key in Kenya as we train more people in around the country, here in Nairobi University and even at Moi University. And I think there's other centers which may come up. We need to talk about it. Talk to anybody. Don't wait until they are sick. Talk about cancer. Say it's treatable. You don't have to go to India to get treated. We can treat. Most of these cancers are treatable locally. So those are some of the strategies we need to use. In terms of prevention, secondarily, we could also use, there is massive vaccination now which is free from the government, and this is given to children in primary school. That's the target. Before they are sexually active, from the age of 9 to 26, that is the age recommended, but it has been extended to about 45 years by FDA. This is approved. NHS recommends vaccination for both girls and boys at the age of 12 and 13. What I don't know is whether we are doing this to the boys in our setup. I know the girls are receiving. The vaccine actually aids to prevent cancer attributed to HPV, that is cervical, vaginal, vulval, and oral, anal, throat, and esophageal cancers. So this vaccine, if it is widely used, it's going to help our community in a big way, because esophageal cancer is really high in the risk category of the cancers. And even colorectal, although all these things are tied together because of the virus. Screening of precancerous lesion is something we need to understand, because if we approach the screening very seriously, this can be done by everybody. And once you make that diagnosis, then you refer to the specialist who can do further follow-up as required as by the protocol. Pap smear, conventional pap smear can be done liquid-based, thin layer, cytology can also is very useful. Between the age of 21 and 25 years, it is advocated that we do it once every 3 to 5 years in countries with good resources. Poor resource areas, WHO recommends that from 30 years, every 3 to 10 years, this should be done. And WHO stops screening much earlier at 50 years if the last 2 consecutive screening results are negative. This we shall see later that American system carries it to 65 years. These are innovations which are being done at a trial level. Urine testing for HPV has been proposed but is not clinically available. This test method may have utility if HPV testing alone without cervical cytology is used for cervical cancer screening. So we'll wait to see whether this will be something to fall to. Menstrual blood sampling for HPV testing has been described and may be a convenient approach for cervical cancer screening in premenopausal patients, but further studies are still needed for us to talk about it more. American Cancer Society guidelines for cervical cancer screening are there. Less than 25 years is not recommended. Between 25 and 65, HPV tests done alone every 5 years is preferred. Co-testing, that is using 2 testing methods, every 5 years, or cytology alone can be done every 3 years as accepted methods of screening. After 65 years, the screening can be discontinued if adequate negative prior to screening has been established. Individual ages greater than 65 years without documented prior screening, it's advisable that this should continue, the screening should continue until criteria for cessation are met. I know Professor Juang may have something to say later. I would like to hear what he will say, because in our setup, we are discovering people older than that, and we cannot say we are not going to treat. My own sister, who was over 70, was diagnosed, just was going for cystitis, and then somebody saw a nodule, just decided to biopsy. It was cancer. She landed in hospital the next week. The later treated her. She's been free for over 5 years. So we need to think of our setup, not blindly following figures. Adequate negative prior screening is currently defined by as 2 consecutive negative primary HPV tests, or 2 negative co-tests, or 3 negative cytology tests within the past 10 years. Still on these precancerous lesions, pathology may not actually distinguish between CIN3 and CIN carcinoma in situ. So we don't even see that reporting now of CIN carcinoma in situ, because CIN3 is as good as saying there is possibility of cancer within. So it is taken that serious. Terminology now is in 2-tier. CIN1 is categorized as low-grade lesion, and CIN2 and 3 are combined into the category of high-grade squamous interepithelial lesions. Glandular precancerous changes include adenocarcinoma in situ, and their treatment is much more aggressive because of the anatomical appearance of cervical canal. These are terminologies we need to be familiar with. This correlation between dysplasia, carcinoma in situ, cervical intraepithelial neoplasia, CIN, and Bethsaida terminology. This is just a summary to show that originally we used to report our pap smear as normal, atypia, coilocyte, and all that. As we go to the extreme right. I don't want even to concentrate on the middle. That is modified terminology which was there earlier. You will find that Bethsaida, which came to being in 1991, now reports normal, within normal limits, as benign cellular changes if there is evidence of inflammation but no atypia. If we come down, if there is atypia, then it is taken as ascus or typical glandular cells of undetermined significance. And the treatment, we shall see what we do, just as a summary quickly. And going down, you find the CIN one is referred, as I've told you. I don't want to go down. These are just a reflection of what I've just been talking about. Treatment of CIN. Effective treatment of CIN implies eradicating the whole transformation zone and not just the lesion. This is achieved by excision or destruction of the transformation zone. Whether the transformation zone is being excised or destroyed, ablation to a depth of 7 millimeters is considered optimal. The basis is that the deepest gland rift can contain CIN as low as 4 millimeters, and destroying to 7 millimeters gives a sufficient degree of safety. In fact, during cauterization, another 2 to 3 millimeters will be destroyed as the process is going. So it will end up being maybe deeper than the 7 millimeters, which gives us good clearance. Of course, we don't intend to do, this is achieved by using the right thermal energy. Treatment of CIN1, we normally follow them up to 6 months, follow them up 6 monthly to see whether they will go to a higher grade or remain steady. If the CIN1 passes for 2 years, a loop excision, electrosurgical excision procedure is done. What? Before using any ablation, cryo or laser therapy, a negative ECC endocervical canal curating should be obtained. I think I have to summarize this. The treatment of CIN3, I think most of us who have been seeing the processes being done, in summary, excisional with conization can be done, and lip procedures after colposcopy. Let me not just belabor there, let's move on. This is a summary of a triage of all these lesions, and the notes will be available for people to see. The sensitivity and specificity. For any screening procedure, the sensitivity and specificity must be high for it to give you good results. Screen and treat protocols are also a good option, but we don't do it in our setup because the results take a turnaround time is a bit long, so we normally give them an appointment to come for the results. Otherwise, you can do the treatment in one sitting if you had a laboratory next to you to give you results. Alternative inspection methods can be used to screen. Visual inspection of the cervix with naked eyes, also referred to as direct visual inspection or cervicoscopy, every 3 years is an alternative approach to cervical cancer screening in resource-limited setting. Rather than not being seen, at least do a speculum inspect and see whether there are changes which require treatment and maybe referral. It can be performed with acetic acid, VI, VILI, which I think you are familiar with. Others, we can, I think I'll not repeat lugoliodine and VI because of time. Role of combining two screening methods. Combining two screening tests, e.g. HPV followed by VI or cytology, has been described as the preferred screening test in resource-limited setting for patients with HPV. Because HPV is very aggressive in terms of progression of neoplasia, so doing that core testing helps to pick any early changes which may be there, for us to be safe. Other tests I don't think I want to go down into that. New innovations are the use of optical device to either triage HPV testing or to use as a primary screening test. This is a method which uses smartphones, and a picture is taken which stores the data, and essentially this works like a colposcope. Give me a few minutes as a healing process. Thank you. Ultimately, these devices will rely on artificial intelligence. That's where we are going. I know it will take time, but clinical validation is usually very, very important, because we cannot just jump to this artificial intelligence unless it has been done and it has been tested and results have given us beyond any doubt that it can be relied on. Patients with HIV are a special group, as I've described. They have increased risk of cervical intraepithelial neoplasia, and they need to be aggressively followed and treated by all screening methods. CA ovary, Professor Ojwang has alluded to what happens in this, and I don't want to go down into that. Risk factors are given there, genetics, age, and all that, and early menarche, late menopause. This is, in summary, when the ovary has been ovulating for a very long time. That gives a risk. There is a theory that trauma to the epithelium of the ovary is very essential in stimulating that. Also, other things which I may not say is the mutations of the body defense mechanisms which arise and make the defense mechanism weak and allow these cells to progress. That's for another day. What is very important, and we have been told there is a lack of reliable method for cervical, for ovarian screening. So examination is a must. Pelvic examination, which includes speculum and digital exam, may give you a hint, then followed by, we can do CA 125 if you are high suspicion index, but it is not reliable, but it gives you a hint that you need to watch out and check whether the cervix is affected. And clinical examination forms a very big thing, and ultrasound in terms of helping us. Transvaginal and otherwise. Endometrial cancer was covered by my colleague, Dr. Mokomba. I think I'll be boring you. You need to go for lunch before. For the vagina, it's referred to as Switzerland, because among the genital organs, that is where nothing bad happens, only good things seems to be taking place. A baby comes through, and other things. So it does get cancer, but if it is in the lower third, it's considered and treated as vulval CA. If it is in the upper third of the vagina, it is considered and treated as CA cervix. In the middle is when we can think it is a primary vaginal tumor. It can be primary also, it can be secondary, when it is in the middle portion. That's how we manage the treatment, and most of the treatment is surgical and radiotherapy. Prevention, HPV vaccine, as we have, because most of these, I am not going to talk about that. Our references were that, and thank you very much for giving me your ears.
Thank you. I don't know now if, thank you very much, Prof. Cheserem. I think we are almost sleepy. Now, I don't know whether Prof. Cheserem will take questions. There, we do a panel. You had wanted to do a panel so that you will sit here with Prof. Ojwang and the other presenters in the morning.
It's okay.
And Mr. Kimani, I don't know if that will be a good, so that we just have a discussion, like a panel discussion. It's not.
Yeah, for the audience, I was having a Zoom meeting as from 7.
Okay.
With Ogengo, and it was for chairman, and I'm a chairman.
Okay. Okay.
lot to me.
Right.
Something to do with the upcoming exams and payments and all that.
Right.
So is there any question for Professor Cheserem?
Any questions for Prof. Cheserem? I know she's covered the strategies very well. Yeah, any question? Yeah,
Yes.
Carol Odula, please. Yes, and Moot and...
Anybody with a question?
Yes, Carol,
Okay,
Dr. Carol Odula is...
It's so interesting that we have evidence concerning vaccination, but the message doesn't get to the ground. Is it us who packaging about communication, because the evidence is there? What is it that we're failing? Because parents are scared of this vaccine. There are many people, even gynecologists, who come and tell you about association between vaccine and cancer. What are we missing, Professor? And
I
really
think doctors, we are a special breed of people in the sense that we don't even advocate what we should be advocating.
Yes.
And I see that we have a lot of laxity in terms of advocacy. You have an opportunity to go to Ramogi Institute and talk Dholuo. I have talked in CAS FM Kalenjin Forum. With somebody who has been suffering, just to hear your word. They may not take the treatment. Them what it means to take chemotherapy and all that, but you must support them at all costs. But you must do your bit. So even in Kasarani the other day for a retreat for women in my church, and people start coming. I even offer free checkup. Our friend, our colleague who came here today to speak about their own personal experience. Otherwise, in the village, people just know you. Once it is said, it has happened. I have a relative right now who was diagnosed with cancer of the testes, and he had 2 children, fortunately, but he did not get radiation. It was Our government is now trying to put a caveat on us. I don't know whether you are aware that if you write a letter referring somebody to India, you will be called to Ministry of Health and be carpeted by a panel of those people to be shown what is it. You go on your own terms. They will not refuse, but they don't like you referring and saying we cannot manage. That is the way it is. Professor Juang has been doing a lot. a.m. Us telling us how we are going to theater, this should go, stop this one, do this. We are his products, and we are very proud of that. Now, as the chairman, I have taken another group who are now finished. They've just finished their exam. They are going to second year. And I've already, I'm going to admit next week, do interviews, and I want to take 10 because they are really coming. They want to come. Okay. Some are waiting list. Thank you.
As you can see, me, I've done my job. Others can take over, but I'm behind. I'm looking from far, whether the proper thing is being done or not. Yeah? And if I find that proper thing is not being done, I'll come in front. Yeah? For that very good presentation, very nice presentation, I've been given something here to give you. I don't know what it is, but I think there's an umbrella inside. Yeah.
Yes. Yes. Yeah. Give the hands. Yeah. Go. Yeah. Thank you. Thank you. Thank you, Prof. Thank you, Prof. Ojuang. Thank you. We still have more gifts, so yeah, they still have presentation. Yes. Yeah? No. Ah, okay. The sustain. Yes.
I'm the one who introduced it with those who are there.
Okay. Give a gift, eh? Oh, okay, after presentation. Okay. Okay. I introduce. Now, we'll have a presentation from our sponsors who have been with us for a very long time. Their presenter also, Mr. J.
Through Sun Pharma at a glance and the basket of gynecology products that we have. Sun Pharma at a glance, we are the 4th largest global generic company in terms of specialty. We are number 1 in India. Also been in this market for about 30 years, reaching people and touching lives since the year 1993. And we are committed to gynecology with our range of products. We tend to think of ourselves from contraception to conception. There is something for you in the basket of gynecology products in Sun Pharma. We have our OC pill range, that is Dronis and Delcia, that combines the power of a 4th generation progestin with ethinyl estradiol. We have Sustain, the natural micronized progesterone, courtesy of whom you've had a presentation just a couple of minutes ago. We have Ranferon in capsules and syrup for all the hematinic needs of your pregnant moms. Letrozole for ovulation induction, Cabalin for the management of hyperprolactinemia, and also for stopping lactation. Lupride Depot, which is our Leuprolide, the #1 GnRHA agonist in its class for management of endometriosis and fibroids. Very quickly, just to highlight about Sustain and the technology that comes with Sustain, what makes it unique in this market is the technology it comes with, which we call the SLDS technology, the soft layer delivery system, that allows this product to be given in either rectal oral or also vaginal for fast pass effect. The fact that it has LCLDS technology allows it to minimize gastric action, therefore allowing a bioavailability to actually get to better levels without any concern of the concentration, whether you take it orally or whether you take it rectal or vaginal. Very quickly moving to ranferon syrup, the blood builder for the entire family. It also combines the benefits of folic acid, vitamin B12, zinc, and ascorbic acid. As we all know, ascorbic acid improves the bioavailability of iron. It is the only hematinic with a high elemental iron in the market, whereby the syrup gives 41 milligram and the capsule gives 100 milligram. To talk about our letrozole, which is a new perspective in ovulation induction, we'd like to say that when you compare it with clomiphene, letrozole provides significantly higher ovulation rate, significantly higher live birth rate, and a higher rate of pregnancy. And there's also comparable birth weight of newborns that have been conceived after letrozole treatment to natural conception with only a difference of about 0.02. And this product also is highly recommended as first-line by world-renowned organizations, the ACO Group, Endocrine Society, the World Health Organization 2016 guidelines, so it's a product you can trust and use for ovulation induction. Also proceeding to another brand, our Lupride Depot 3.75, and we also have 11. It rectifies the problem of endometriosis and uterine fibroids. It can be used both pre-operatively or post-operatively, and currently we have an offer on this product. The 1-month injection going for 3,500 and the 3-month injection going for 7,000. Moving forward to Carbaline, which lowers prolactin effectively and can also be used in the treatment of infertility that is associated with hyperprolactinemia. It scores against bromocriptine. If you look at how it normalizes prolactin levels, how it restores the menstrual cycle, it also offers a very high pregnancy rate that is quite comparable because it is 82% and 56% for bromocriptine, better tolerability in terms of adverse effects, and greater galacturia suppression. So I'd like to just talk about our OC pill, Dronis and Delcia, and what is the difference of these particular products. Delcia offers the conventional woman the normal regimen, 21+7, while Dronis offers greater ovarian suppression by providing the modern woman with a 24+4 regimen. Both the OC pill combines a 4th-generation progestin, drospirenone, and ethinyl estradiol, where Dronis has a lower level of estrogen because it has 0.02, while Delcia has 0.03. Now, one of the things about the progestin this particular OC range has is the advantage it has in terms of anti-androgenic effects. This is one of the reasons why you should choose this product when you're managing PCOS, because on top of giving greater anti-androgenic effect, it also has an anti-mineralocorticoid effect, which means it has a good profile when it comes to weight. It ensures no weight gain, and it also has lesser water retention, which also means in terms of BP, it is better. So if you have a patient who has a high BMI or you have a patient who has issues with BP, this is the right progestin to put your patients on. What is the difference in terms of administration? Dronis offers 24+4 pill-free days, which means it has lesser pill-free days. All the women who experience premenstrual disorder or women who have had withdrawal symptoms, when you give Dronis, you lessen the days that are on pill-free, and so this means they'll have lesser incidence of the symptoms they experience once they withdraw from the OC pill. Delcia is the conventional method. The indication of Dronis is oral contraception and mild to moderate acne, particularly in younger women who need greater ovarian suppression of 24 days. And Delcia, oral contraception and cycle correction in the conventional woman who does not want to change from the 21+7 regimen. And in terms of the preferred user, Dronis is better on younger women, women who want lesser pill-free days. So this means they have lesser withdrawal days with greater ovarian suppression of 24 days. Whereas Delcia can also be put on the obese women and women with high BMI. These are older women, and also the levonorgestrel users who want to maintain a similar pattern of 7 pill-free days. Kindly remember that drospirenone scores greatly over levonorgestrel in all aspects. I would like to thank the organizers of this particular project and today for giving us the platform, and we look forward to more of these. Thank you so much, Dr. Odula. Thank you so much, Dr. Mbruto.
I'd like to appreciate all our speakers so far and all the participants and attendants. Now lunch is served. Oh, we can hand over one gift to Professor Juang and also Washington Kimani.
But still be there for the afternoon session. I'm sure we will be having 30 minutes almost for lunch, if not less, that we keep time. Thank you. Thank you, everybody. Lunch 1:30 to around 2:15. That we do 1 hour. Thanks. Utaweka screen off, sawa.
And good afternoon, ladies and gentlemen.
as we wait for the IT. Yeah, thank you, Moledina, for that presentation. I'm saying sometimes the best comes last, but we also want to know that certain things come at their own time. Just when we were discussing, I said it's Reproductive Health Symposium. It's been a cancer year. So let's think of something cancer. I know we've talked a bit about IVF, fertility, but I'm happy Grace has also touched on preservation, which I think will be a key area in my discussion today. Most of the speakers previously since morning have talked about many gynec cancers, all covered by Prof. But what it will be important for us to look at is, yes, we are making big strides in treating cancer. But what happens to these, both men and women, or young boys, girls, even young children who are treated for cancer with things that probably could affect their future reproduction? So I said, let me veer out from the common gynec cancers we are looking at and look at the effects of cancer generally in this group of people. Now the question will come up, what is the lowest age of reproduction you want to think of? What is the highest? And I think those things will be clear by the time we are finished with the presentation. So Dr. Moledina, I think, has done his part to say a bit of what I am. Most of the people who talked in the morning, Prof, they are our teachers from University of Nairobi. Yeah? I'm also interested in a bit of laparoscopy, and I did my ART in UK. So thank you very much. Without taking so much time, I just want to bring to your mind that there is what is called oncofertility. I know Prof. Ojwang talked of oncology. So my take-home point today, even if we don't remember anything, will be oncofertility. I know the lawyer, Dr. Diana, will also probably touch on legal areas. I was just talking to her, and I was trying to juggle her mind to look at legal, ethical issues, because as we go, you will realize there are so many ethical issues. The gentleman who was here much earlier, what was his name? Do you remember? We are all asleep. Washington. Yes, Kimani. Now, if he's to come and see our good lawyer and say, well, the time I got diagnosed with testicular cancer, I'm not, now that he has talked, I'm just putting him as a face also. The time I was diagnosed with testicular cancer and probably later on leukemia, and I was married and my marriage fell off and I was seen by a doctor, did they think of my fertility? And I want to take them to court because probably that was not taken care of. Where will we be? So sometimes you help patients, but at the end of the day, if you look at the way things are going, you have to think what is there in the market so that we have good practice. Now, as we move along, I want to talk about fertility preservation in women. I technically took women and not men. Maybe you'll ask me why. Men is just another gray area, like when you talk of what was there. We were talking of breast in the morning and we didn't know whether it belongs to the surgeon or the gynecologist. The same way when now it comes to issues to do with male fertility, you are not very sure whether it belongs to the fertility specialist like us or it belongs to the reproductive urologist. Because it's easier, people say, oh, you can come and give sperm and all that. Yeah, but then when it comes to invasive procedures, in terms of getting those tissues and all that, then you might want to think of what could be the legal implications. So my outline will be a bit simple. I'll just juggle among a few things. I'll give some introduction. Just want to look at what are the indications of fertility preservation, especially in women. We know in men also it's there, but for purposes of discussion is a big topic. I'm going to go mostly for the women group. And of course, look at a few strategies for fertility preservation, which we'll see as we go. And then probably look a little bit at stimulation protocols that are safe in fertility preservation and in an oncofertility setting. Of course, I also want to put a lot of emphasis that oncofertility is a new area, and my topic today is not to give you a lot of science, but is to bring about awareness that this is an area of concern as we are beating our chest that we are making strides in treatment for cancer, be it surgical and be it pharmaceutical. Then we need to look at it from this point of thinking so that we help the patient wholesomely. Most of the patient will survive like the way he has survived. So there's a paradigm shift from treatment to survivorship. Now survivorship is now where you want also to reproductive health, is a right. So you need to get that also sorted out. Now, oncofertility is what mainly refers to fertility preservation for cancer patients. I know most of you also will think about the other fertility preservations, not necessarily for cancer, but I will want most of the talk mostly to go on looking at cancer patients. They are social fertility preservation, people who probably are in career, the right man is not there. Could they do preservation, those group of women? So those are thoughts that we want to keep as we go along. Now, just as I said, improved cancer surveillance, as we have seen earlier on. Everybody talked about strategies for detecting cancer, and treatment regimens. There have been a lot of treatment discussed about. Dr. Mukoba, my colleague here, now is a cancer specialist. We start engaging now. I'm not a cancer specialist, so I'm not going to be stepping on their toes so much. They'll do the rest, but now we discuss on fertility preservation and options. Be it even surgeons. Surgeons have the breast, if they do. Do they know that these are patients probably also who might need fertility preservation, especially if they are going to have those issues of treatment and chemotherapy and stuff like that. So just to joggle your mind, we know treatment regimens on malignancy affecting women such as breast cancer, which we know is quite prevalent in our setting, as we have seen earlier on. Cervical cancer, we talked of early sexual debut. So you see very young women who will come with cervical cancer. What do? You might end up wanting to do a hysterectomy or probably other surgeries, which might affect their fertility in future. Is that put into consideration? So as we speak, maybe by the time we finish, you'll tell me whether we need to get oncofertility as to coexist with cancer treatment management programs as part of something that is cast down. Of course, lymphomas, leukemias, as you just saw, the patient who was here, these are the most difficult ones, blood-borne diseases, and probably fertility preservations. But with improved treatment in the pharmaceutical industry, then we see most of these patients, and also in the gynae surgery, we see most of these patients living and even forgetting the disease. All right? So we are now going to shift the paradigm also, not just from treatment and screening, but also from long-term care that I think should be an area of concern. So the advances in reproductive medicine can now allow patients diagnosed with cancer during their reproductive years to undergo various fertility preservation options, which we are going to discuss as we go along. And therefore maintaining a potential of childbearing following successful cancer treatment. So a lot of questions will come up. How do they resume their fertility? How long do you want to give them? So all this will be a concerted effort. It's not the fertility specialist to decide Then you have to link up with the oncology team, so that there are those ones who get relapse. There are those ones who will have a small window whereby they can just go back to their normal fertility, as we are going to see. So just looking at the background, we know globally the incidence of childhood cancer is quite high. It's quite high, and sorry, I was to put my marker. As you can see, with almost 12% over the last 3 decades, and it's increasing. So we need to be worried, not just not just at. No, I wanted to put a pointer, but that's fine. Sorry. It's okay. Just go back. Okay, there we are. Yeah, there. Thank you. It's okay, there's no point for that pointer. So I think there we covered. I think we are looking here. So there is a global increase in most cancers, as you can allude. And there are new cases every year. Approximately even close to 1 million new cases have been diagnosed in young adults yearly, globally. And some of them will be within that age group. These were some statistics. The question is, what is being done? In the Western world, the shift is now going to areas of fertility preservation and future fertility. Because at the end of the day, these cancers will bring, the mortality might be very high, and the number is big. So in the future, if we are not careful, they are going to affect, of course, our populations. We'll have a lot of issues. As we are going to talk about psychosocial with Rachel, I'm sure she will touch on that, maybe in her presentation. In sub-Saharan Africa, the incidence of childhood cancer varies between that much. Though in our setup, data is an issue, there is paucity of data. I only saw Dr. Maranga trying to look at some data in the morning. So this is one area I think we'll need to improve so much, so that we have data also that is going to inform our decisions. Sorry, I don't know why it's going in front. We have data that is going to inform our decisions and our policy. Okay? Yeah. So, as we have just said, of course, Kenya, I tried to look for data, and I couldn't come through much data. The only data I got was from Kijabe Hospital, where somebody did a survey to look at the common cancers. And it came somewhere near to what we can see here, with common cancers being Burkitt's lymphoma and Hodgkin's. I'm just looking at those ones that might also have fertility issues: Hodgkin disease, Kaposi sarcoma, gonadal cell tumors, acute lymphoblastic leukemia, Wills tumor. So looking at this, this might be, and it affects people from different groups. I saw my colleagues in the morning, everybody who gave presentation, talked more about cancer in maybe a very high age. We are talking of 50s, 60s. Yeah, I see I have a short period. I think I should have given I will flip through a bit faster. So now looking at the long-term effects, they have said there is global paradigm shift towards integrating the quality of survivorship care to integral cancer care. Okay? There are potential late effects of cancer treatments also include largely reproductive and endocrine factors, among others. Now, there is the issue of affordability. So in our setup, patients literally don't have the money to take care of cancer. So if you're bringing in another aspect or another angle, then it becomes quite not easy. But in high-income settings, these are significant concerns among childhood and adolescents. I've talked about paucity of data. on late effects and infertility, and even on pregnancy. Sorry. Okay. Now, this just to give you a scenario when you want to think about the effects of cancer treatment on women's fertility. It's important to know that there are primordial cells which ovarian reserve, which declines with age. So this might quite be affected depending on what stage you give cancer. So you might want to give your cancer, if you give your cancer treatment for maybe a child who is on that end, might not necessarily be the same effect you might have maybe for somebody at puberty. Sorry, I didn't put my, at puberty, or even towards the late reproductive age, as we are going to see. Because, of course, there is a decline in ovarian reserve. So this just to have behind your mind is a very common picture. We look at it, especially when we want to look at fertility and the effects of fertility and age. Now, looking at the several prognostic factors that will lead you to premature ovarian failure during, we know two of the big areas of treatment will be either chemotherapy or radiotherapy. So when you're giving chemotherapy, I think it is important to consider certain things. Of course, the agent you are using, okay, the diagnosis, yeah, and if you are going to combine chemotherapy with radiotherapy, you know, of course, the effect will be much, the effect as far as fertility is concerned will be much higher. Of course, the protocol and the cumulative dose you want to use also will affect fertility, okay? And also when we look at age, the same way I was looking at age earlier on. So there are issues to do with age factor. I will skip a little bit, I will have talked more, but I will make it. So fertility preservation strategies that we know are there. Of course, for the male, we have sperm, we have ovarian tissue, which now, I think by now is no longer research, but it's there. But looking at the women, we have embryo or oocyte cryopreservation. We have cryopreservation of ovarian tissue, commonly known as OTC, which until recently was a research, though it was being practiced. The way Prof said, if you don't treat, there's something he was talking about, if you don't know, you don't treat, okay? So as long as probably you're not doing harm and it's being done somewhere, like OTC has been under research for quite a while, but that did not stop the people in the Western world to use OTC or ovarian tissue cryopreservation as a mode of fertility preservation, okay? There'll also be the issue of temporary ovarian suppression with the GnRH analogs. During chemo, it's not a strategy, but it's just an adjuvant treatment. It's been shown to be gonadoprotective, so some protocols, they will use GnRH, as we'll see. There are surgical areas, translocations, or transpositioning of the ovaries prior to radiotherapy, especially if you are looking at those malignancies that are going to affect the pelvis, and you are going to radiate the pelvis. You can do your transposition of the ovarian ovaries to put them somewhere, the paracolic gutters, but now it will come with its own challenges, probably when you want to do stimulation for this patient. How do you monitor? How do you do pickups? You know, all those. But but I will try to concentrate on the other ones. Okay? Now, these are just fertility preservation techniques in the lab. I will not bore you with that. Vitrification, slow freezing. Each of them might have its own merit over another one, but vitrification is widely used. It's easy to perform. Slow freezing, you might need some of the technical equipment, but vitrification can be done. And of course, the results sometimes are quite encouraging. So looking at the effects of chemotherapy and radiation infertility, then we look at female population between 1 to 39 diagnosed with cancer. Yeah, and quite a big number will require chemotherapy. Most of the chemotherapy sometimes will be gonadotoxic. And to make it easier, so that because it's been shown that it's very difficult for gynos or even the oncologist with the evolving of pharmaceuticals to literally tell that, okay, the treatment we are giving you, sometimes it's not clear-cut, might be gonadotoxic or not. So there's a recommendation that all probably women of reproductive age or those ones you think will have reproduction should be counseled about their fertility. So those are the areas we look at as we finish. So the most common agents that are gonadotoxic, we are looking at alkylating agents or radiotherapy, which of course the dosages are based on the, what they are giving. Okay, can be gonadotoxic, especially, which I've said, if it's geared toward the pelvis. You're talking of total body radiation for certain cancer. They can result in ovarian damage leading to infertility. Okay, the male we have said we'll skip for now. All right. So of course, some of them will lead to acute ovarian failure, whereby menses cease. There are some agents which might potential, and from acute premature ovarian failure, they might end up having premature menopause, okay, when you're looking at this group of women. So these are areas that we have to think of. So all patients exposed to gonadotoxic chemotherapy will end up with a decreased ovarian reserve. Thinking of the first picture we put, all that reserve sometimes is brought down with this gonadotoxicity, with potentially leading to infertility and a significant predisposition to developing premature ovarian failure. Okay, so these are just put up here intentionally so that we look at our radiotherapy department. I'm sure they do a lot of radiation. So premature ovarian failure during radiotherapy, these are the areas, even as we radiate, I think our radiotherapy should think, what is the age of the patient? We know that will have effect on treatment. Dose of radiation, extent of the radiation field, and type of radiation. So this just to bring your mind on that. Now this is a predictive age of ovarian failure after radiation to a field that includes the ovaries. Looking at our first, the first ovarian reserve decline with age, then you can see that effective sterilizing dose, I don't have, I needed to have a pointer, you may not see the colors, but of course with a lower age, maybe at birth, for you to have issues with those ovarian reserve, you need a very high dosage. Yeah? And that decreases with age. Okay? So with age, very low doses, you get very bad effects. Yeah? So that's the message I just want to allude here, but I will go a bit fast so that I don't bore you. Yeah? Sorry. Oh, still. So this is a chart just to show patient with receiving, for instance, chemotherapy, and the effect on maybe premature menopause or premature ovarian failure. At that age, you can see the physiological decline, but now you can also appreciate those ones who will have premature ovarian, premature ovarian failure that will lead to a premature menopause. But also we have the group that will have acute ovarian failure, okay, with acceleration of the treatment. Now, these are just some of the risk factors which we have talked about. Alkylating agents, high risk, cisplatin, doxorubicin, intermediate, antimetabolites, low risk. So this just to highlight, I think those could be much for the oncologist. Of course, the other non-malignant pathologies that will also bring you the risk of premature ovarian failure. And in our setup, high on the list, sickle cell disease. Most of them will need probably treatment with stem cell therapy. Yes, I'll try to be faster. Most of them will need treatment. So this is also another group that might need fertility preservation. So I will just go more about. These are some of the tumors that we'll be looking at that can give you, that will make you think of fertility preservation procedures. For purposes of time, I will try, because I still have some more slides there. These are just the options of preservation in the lab setup. Of course, oocyte preservation, embryo, which can be preserved in most stages. And of late now, we have ovarian tissue cryopreservation, which is it's considered as a method for preservation. It's no longer in the IRB group, the research bureau, because it's already there and being practiced. Of course, the other pharmacological protection, like GnRH analogs during stimulation. Now, so of course, these are established, the established ways of fertility preservation. Some of them, of course, you need sperm, some you might not need. So the issue of timing, because cancer treatment also before it's diagnosed, there's very short period to make these decisions. So the issue of timing before you do preservation is also crucial. And for those ones who will undergo, for instance, ovarian stimulation and oocyte retrieval or embryo for that matter, you need approximately 2 weeks, all right? For OTC, you might need shorter period, so ovarian tissue cryopreservation can be done in a much shorter period, but we'll see which patients can benefit from that. Okay, so births have been recorded, reported in adults from ovarian tissue cryopreservation, and of course, transplantation later in life, either autologous or autotopic. All right, and even some of them have resumed their cycles post-transplant. Okay, so OTC is the only method that is feasible for fertility preservation in prepubertal girls. So we are talking of this group of women who have not had their menses. You might not stimulate them, or very young children. OTC is the way to go, all right? I think that's important. Also, there is the use of IVM, which can be used especially after you've taken tissue. So you don't need stimulation. This might be good also for patients with ovarian cancer, which are estrogen. And you know, of course, there's an increase of estrogen during treatment, which might bring about issues. So those are the areas we'll talk. That one I think I will skip because my time is up. Looking at the protocols for fertility preservation, it's just like the protocol for IVF. Of course, you can do your stimulation with the GnRH antagonist plus FSH. Of course, if you are doing ovarian tissue, you can do your laparoscopy and get your tissue even on day 2. All right, and if you are going to aspirate follicle on day 12, you can do it. All right, for those ones you are also doing, for instance, they are coming in their luteal phase, you can do GnRH agonist, depot injection, and you still do something in the luteal phase. And of course, you could start chemotherapy within even 2 weeks of treatment. So this shows you that time can be worked on, but it has to be a multidisciplinary. So just, sorry, I will take more of time, but I think we have to bring the message home. So the European Society of Medical Oncology recently recommended that all cancer patients of reproductive age, all, probably not those ones who are just having, for instance, you may say they are gonadotoxic, because that's a challenge, but they should receive complete oncofertility counseling. So we have not talked of treatment, but counseling. So that awareness has to come there as early as possible in the treatment planning process, irrespective of type and stage of disease. So this just to show you the flow of how patients should flow. This was the one that is talking about, especially if you're evaluating for the risk. Okay, there is one slide that I think we've missed there, but that's okay. So I just want to emphasize this is an interdisciplinary workforce in the oncofertility. It's not a one-man show. We are looking at oncology, pediatrics, reproductive science, where you are looking at reproductive endocrinologists and fertility specialists, reproductive urologists, because there is the issue of urology that can be there, pathology, the lab is there, but bioethics should be looked at. Religion, somebody talked about it, we need to think. Policy research, reproductive health laws, that needs to be among others. So this just to say it's interdisciplinary. It's not one person. Mine is just also to just bring the awareness. So as I conclude, then as early as possible after diagnosis, all women diagnosed at reproductive age should receive complete oncofertility counseling, irrespective of disease stage. Okay? I think we should also look at the age, though the age might be challenging. There's a slide that is missing that probably will have shown the flow, but I think it's not there, but I will not bother you. Maybe I can give it in another talk, another time. So women or females scheduled for any gonadotoxic treatment should also be offered the option of fertility preservation prior to commencement of treatment. And of course, we want to acknowledge that there is a huge unmet need of fertility preservation services generally. I wanted us to look at some, but we are not going to look. This is just to show that, I will just read there, but we will not look. I'd wanted, if we had time, I'll do it probably in one of the presentation, to look at a case scenario and several things. Sickle cell disease in a prepubertal or maybe in a child, 9-year-old, seen at 8 months, what do you do? Breast cancer in a young female, what's the way forward? Cervical cancer, married female, what's the way forward? So these are areas, but I think we need another forum for it. If I do it, we might not go. Leukemia, we talked of it. Single young adult, where do we go? Yeah? So all that. So these are a few of the references I had, and thank you very much. I've taken more than time.
Thank you, George.
Thank you very much.
Thank you very much,
So
George.
now,
And you can see that he's very knowledgeable. He can't cover in that short time. We'll keep a separate symposium for you, 3-day symposium. Thank you very much, George.
Thank you. Thank you, everybody.
I introduce my co-colleague, Dr. Diana Ondeko, who will now introduce the other speakers.
Thank you. Our second speaker is Sister Rachel Marigi. She is a Kenya registered health community nurse since 2011 and has worked in various health institutions. She's a palliative care nurse at our cancer center here at the Nairobi Hospital since 2017, working with multidisciplinary teams in provision of supportive care, wound care, and support groups to our cancer patients. She'll be speaking on the psychosocial aspects of gynecological cancer, and we know it's extremely important that we deal with the well-being, mental well-being of our patients. So welcome, Sister Marigi.
To say, as she sets up, what Dr. Ogweno has presented is so real, and we see many of these very young people about actually teenagers, 16 years, 15 years with ovarian tumors, and always there's that dilemma about what to do with the fertility. So this is very exciting. We are now seeing very young women with cervical cancer, 25 years, 20. What about their fertility? I think the other main challenge is the costs. But like he said, our job is to counsel them. Those who can afford will go for it. Later they won't say, probably if you had informed me, I would have looked for ways of taking this option. Thank you, Dr. Ogwen.
I'll also be available to take questions. I'm not immune from questions, even if I'm the chair, but I could take questions later. Yes, you'll say. Thanks.
Good afternoon, everyone. I want to take this opportunity to thank the team for inviting me for this presentation. Before I begin, I want to acknowledge the oncology nursing team who are present here. Can we? I believe Dr. Ogweno, they've really taken the topic well. So I'll be introducing the topic as psychosocial aspects of gynecological cancers. Gynecological cancers usually induces a major break in everyday life and a threat to existence for both patients and their families. And many gynecological cancer patients experience physical, psychological, social, practical, and economic challenges during treatment, but also may experience difficulties as long-term survivors, as we can allude from our previous discussion from Mr. Washington. Although during the past decade there have been great advances in treatment of cancer, treatment strategies are still debilitating. Patients' life usually cause decreasing respiratory capacity, pain, fatigue, suppressing immune function. In addition, psychological stress, anxiety, depression, and fear of recurrence. And most of them usually have sleep dysfunction. Also, symptoms which may occur after cancer treatment that worsen quality of life. As a premise, I would like to use one of a case I've been come across with of a 30-year-old female who was 5 months pregnant, was diagnosed with cancer of the cervix, stage 1B. We were called in because the patient had already discussed with the gynecologist on issues of decision-making on treatment because she was being told if they could be able to terminate their pregnancy. Alongside that, she was also a newly diagnosed HIV. So there are so many ethical dilemmas and so many psychosocial issues which we can use to be able to discuss some of the psychosocial aspects. So we'll go through diagnosis, treatment, emotional issues, social issues, sexual issues, and spiritual issues. So during diagnosis, most of us, we've been told about screening, but you find that there has been a low uptake of screening because of fear of cancer diagnosis. And during the waiting time, you find that people have anxiety and fear. During the doctor's visits, most patients will have, of course, stigma of the cancer, uncertainty of prognosis, and as of course, guilt about the cause of the disease because most of it is associated with, for most people who believe it's HIV and HPV, and that could result to issues of unfaithfulness in marriage, especially for those who are in marriage. Today, we've also been told about information. You realize even issues like infertility, not everybody knows on how to give information and counseling on it. Issues on decision-making around treatment, like a case I've also said before, there are issues of discussing issues on decision-making on treatment. And then, of course, with cancer treatment, there is the recurrence and metastatic disease, and also social support issues, especially maybe work, family, and also cost of treatment. During treatment, people are worried about hospital admissions, fear of treatment, also decision-making on treatment, and of course, the many myths surrounding treatment side effects. Then there are issues of fertility, sexuality, body image, especially after surgery, and also onset of early menopause for patients who are younger. And of course, with the anticipation of physical side effects that come alongside chemoradiotherapy. And also, like we said, cancer treatment is not cheap, and also the issue of fear of recurrence and treatment failure. Most of the time, we deal with the issues surrounding pain and symptoms, but usually, to see a patient as a whole, they usually have emotional issues, which are fear of unknown, fear of pain and suffering, fear of abandonment. For example, you can remember there was when Mr. Kimani was saying that the spouse deserted them. So there is also loss of control, suicidal ideations. Others present with anxiety and depression, and body image issues. Social issues surrounding patients, especially for women who have gynecological cancer. We have issues of cost, of course, stigma, most people will be able to express that because they are not able to relate with other women, they usually isolate themselves and, of course, disengagement. And because of the many hospital admissions, you'll find they'll have issues with work and employment. And then, of course, if, let's say, the mother is the one who is sick, of course, there are changes in role, especially in terms of provision of stability at home, in terms of doing roles in the house. And then relationship between the spouse, there can be strain, avoidance, either dependency or spousal desertion. Others have reported also to have divorce. And of course, like we've been told, some diagnoses can be made as early as 16, especially for ovarian cancer, others in their 30s, others in their 60s. These people have life goals, and you can imagine as a 16-year-old who is thinking, I need to be a doctor one day, and then all of a sudden you have a diagnosis of ovarian cancer. You might be able to feel in terms of what their life goals will be like. About sexual issues, which most of the time is not usually discussed, most of them will present with pelvic or genital pain. Others will have decreased arousal, low libido, dyspareunia, of course, issues with infertility due to treatment-related causes, and also the concept of femininity. Most of people, especially women, if you have not given birth, sometimes people think they're not women enough, or maybe part of their organs have been removed. People would have issues with how they identify themselves. And of course, with complex interaction between physical and psychological issues, which also will also attribute to most of these sexual issues. Someone said about religion, of course, this is part of us. Most patients will, of course, be able to have issues with meaning of life. Some people are also angry to God, thinking that maybe they have done something and it brings guilt and blame. Also the issues of hopelessness and loss of identity, and also existential suffering. Even with this, there are factors that can be able to help someone to be able to cope, and some of the adjustment factors are coping styles and strategies, a person's health beliefs, and with advocacy, I believe this can really change people's minds. Then, of course, there are pre-diagnosis, psychological well-being, also importance of social support, the anxiety about the future. Most of the time, people who have recurrence with cancer, it has been associated with psychological morbidity. And of course, there is fear of pain, dying, and death. And also, the adjustment factors can be related with age. Like I'd explained, the level of threat, especially if their life goals with work and family, for the purposes and function which are appropriate to age. So what should we do? It's important to have effective communication, management of total pain, multidisciplinary discussions with patient involvement, caregiver support, support groups, counseling and spiritual care, and of course guided self-determination. So for effective communication, the goals of good communication in cancer care is to build a trusting relationship between the patient, family, and caregivers. I believe when the patient is beginning their journey during their trajectory of illness, during diagnosis, it's important to give information by truth-telling, provide information related to, like we said, treatment, the effects of treatment, need for oncofertility. Even through transitions of care, it's important to continue giving hope. And even during end of life, it's important to be able to communicate this. For effective communication, where has been done, it has really impacted on outcomes, where we have seen enhanced patient satisfaction. Of course, there is increased quality of life. For most, there is reduced patient anxiety and improved symptom control. We also have seen patients with good adherence with treatment recommendations, and of course, enhanced accrual to clinical trials. We have seen improved disease-related understanding and improved prognostic awareness. And of course, they receive care consistent with their patient preferences, especially even during diagnosis throughout to end of life. And of course, for oncologists, there is decreased stress and burnout. We've talked about management of total pain. As aforementioned, we've already talked about the social, psychological, and spiritual. For physical, there is pain and symptom management in terms of dealing with functional capacity, fatigue, and cachexia, sleep and recuperation, appetite, treatment of chemoradiation side effects, so that we're able to reduce suffering and improve quality of care. Supportive care is very important. This is the most critical element in the quality of life. Is whether patients are satisfied with meeting their individual needs and narrowing the gap between expectation in life and achievement. The challenge for the healthcare system usually is to know ways of how to support our patients. And for most, supportive care will be given through the trajectory of illness, from diagnosis, during their treatment, survivorship, for those who will not be able to make it through maybe end of life. And even with this, we continue giving caregiver support. I'm happy that Professor Ojwang talked about multidisciplinary. That was a very long list. So it's not just, there will be psychologists, there will be spiritual leaders, there will be physiotherapists. So with the patient needs, we'll be able to match them with the professional who will be able to assist them. And I'm happy that usually we have a multidisciplinary team in our hospital, and this has really encouraged, in terms of care, I think we have seen improved quality of life, and it has been able to ease suffering among gynecological patients. So in conclusion, gynecological cancers are a major health problem that affects the quality of life of women. Today, developments in early diagnosis, treatment technology has also improved the rates of survival, which has also led to emergence of different psychosocial problems related to cancer and treatment processes. And by helping a woman diagnosed with gynecological cancer, her partner and other family members are able to adapt to the diagnosis of the disease and adjust to treatment process, which forms the first step of a challenging treatment process. And I could not agree more with Patch Adams that when you treat a disease, you win or you might lose, but when you treat a person, I guarantee you will win no matter what the outcome. Those are my references.
Thank you very much, Sister Marigi, for that excellent and concise presentation. It was interesting to see that also stigma is an issue when it comes to cancer patients. We'll be taking questions at the end. Our next speaker is Dr. Asaf Kinyanjui. He is the CEO, Chief Executive Officer of the Nairobi Hospice. He holds a master's degree in management and leadership from the Management University of Africa and a bachelor's degree in medicine and surgery from the University of Nairobi. He served as a Director of Programs, Education and Research Officer at the Kenya Hospice and Palliative Care Association for a period of 8 years. He's credited for scaling up palliative care in Kenya and beyond through capacity building, advocacy, research, networking, and resource mobilization. He will be speaking on end-of-life discussion. What does it entail? So we are looking forward to that great topic. Welcome, Dr. Asaf Kinyanjui.
Thank you. Is it afternoon, evening? I'm delighted to be here. My name is Dr. Asaf Kinyanjui, and I want to thank the organizers for the opportunity. I'm a palliative care practitioner, and I'm happy that Nairobi Hospital has integrated palliative care aspect in oncology care. There's a big gap in many facilities, and causes a lot of suffering and anxiety to patients and families. I'm also not familiar, I'm very interacted with the facility before when we were taking a project on chemotherapy safety, ChemoSafe. I hope you guys are still practicing what we taught you 2-3 years ago. I can see some few guys in this room. But this discussion is about just end-of-life care
And if you are making a construction or you're building up your house, one of the advice I would want to give you is that make sure on your ground floor you have enough space that can accommodate a medical bed and medical equipment. Please consider if you haven't put that in place. I know it's scary, but those are some of the reality palliative care practitioners we are facing as we support patients under home-based care. So palliative care, I think there's a challenge. So palliative care is a broader aspect where we look at the patient from a holistic perspective, as she mentioned. So looking at the patient from the point of diagnosis, once they are told they have cancer, working with them in the journey in terms of managing their symptoms, in terms of counseling, in terms of even having conversations with their family members. And the goal is that we want to improve their quality of life as much as possible. So as you do that, and as a patient continues receiving interventions, maybe chemo, surgery, and such, the disease might also progress. And as it progresses, then you switch your goal more towards supportive care. And that's where you then introduce the concept of end of life. So end of life is part of palliative care. And when you're talking about palliative care, it's just to ensure that you support the patient and the family, especially when the end is near. And your goal is just to make sure there is dignity, there is less suffering, and also you're able to help the patients and the family make very informed decisions regarding their care and their loved one. I've seen there's a lot of migration of patients from rural areas to urban centers to receive care. And it's very important, especially when you're moving towards the end of life, even discuss with the families where would they want to continue receiving care. Because some of these patients would not end up preferring receiving care at home where they are comfortable and probably they're next to their loved ones. And remember also that you also look at supporting the family after the patient has
for these advanced directives and DNRs, and even your forms for how people are filling out their information in terms of next of kin and such things are very clear. We currently have a dispute at the High Court where an estranged wife has come to make a claim as a wife of this estate just because she's the one who was captured as the next of kin, but she has not lived with this person for over 5 years. But because whoever filled out the documentation just took out like from his older medical records, that was there. But all his treatment procedure, everything had been handled by his brother, diagnosis, end of life care, everything had been done by someone else. And this person had a POA. So such conflict may arise just because your documentation is not well thought through or it's not up to date. So I'd recommend that you ensure in your offices you have a good template for a DNR that covers both you and the patient, a good template for advanced directives, and a good template, and where possible, ask for a registered power of attorney. If someone is saying that they've been given authority to make these decisions, then you want to make sure that it's registered and it has that power. So it's simple to get templates of these documents that you can just use, and if you need any, we can share that with you without charging. So how else do people plan for their wealth? So this deed of gifts, or what we call gift inter vivos, is when patients or yourselves decide to give out your wealth. I know the question he said when someone asked, did he say anything about me? Those things will come up. Of course, you know you're bound by confidentiality not to disclose that. But that notwithstanding, if your patient is asking about this, maybe this knowledge is useful for you to, before you direct them to a lawyer, you can tell them that they have options like this. So they could, and this is also now for you. You could, if you have made the decision to go the succession route, you could now do a deed of gift, which is basically transferring the asset A to the beneficiary A. For a deed of gift to be held as valid in law, the transfer, the title, ownership has to change. So if this patient dies before the transfer is done, this property will go back to intestacy, and you know all the issues we have with intestacy and probate and court. So that's one of the ways in which you plan. And then wills, which is what you wanted us to talk about. Let me mention that a will is a legal document. Many people keep forgetting that. It is drawn to specific legal specifications, yeah? So it has a minimum threshold that must be met. It has things like competent witnesses. If someone is an executor, they cannot be a witness. There are grounds for invalidating a will. As doctors, you would know capacity is an issue, so we would sometimes have to satisfy ourselves as to regards the mental capacity for this person to make a decision. We currently have another case we're fighting in the High Court where the beneficiaries, some of the beneficiaries in the will have asked the court to find that a will that was drawn when the person was at end of life and very, very sick and was going in for a major surgery that would have rendered him almost, how do I say it, incapable of doing anything for himself, was drawn under duress because the person who needed to take care of him after the surgery got almost everything. And you have to consider, was he really under duress because he knew, if I don't give these things to you, you won't take care of me. So we are currently before the High Court trying to see how the High Court will deal with that. So it's not just simple stuff. These things come up. So recommend for your patients and even for yourself to draw wills. Another one that I want to mention, before I talk about wills, let me talk about something that is not stated here. Nominations. This is for the staff in your clinics, for your patients, for everything. There's certain benefits that are not subject to intestacy, to the probate process. That's the court process for succession, like pension benefits, WIBA benefits, insurance benefits. So you want to make sure that these documents, this maybe applies to you and your staff maybe, ensure they're drawn properly. So you don't want one of your staff's spouses, if they've deceased, coming to tell you that no, those benefits belong to them, but it's the mother who was mentioned as the next of kin there. So nomination forms should be updated as regularly as possible. We recommend at least yearly, have your HR departments, or at least 3 yearly, have your HR departments send a memo to the staff and tell them to make sure their pension forms are up to date, their WIBA forms are up to date, whichever other benefits that they may be acquiring. So those ones are usually not covered under intestacy. So the final one, and maybe this is more useful even to you, because I'm here also to empower you, is family trusts. So family trusts basically are, they've been reinforced by a law that came in 2021 and some amendments to the Finance Act that came in with Finance Act 2021. Basically, it's for people who are trying to consolidate their wealth and transmit it to different generations, to subsequent generations. So the biggest distinguisher between family trust and wills you'll find is that, number one, for wills, the property is distributed absolutely. So what does that mean? My father dies, I'm named in the will, I get whatever I'm getting and I go with it as Diana. But for a family trust, and this is used a lot with high net worth individuals and families, the wealth can be retained in the Muredi family trust, and I am just a beneficiary of that trust. That allows my children to be appropriate of this wealth, their children, depending on how much the trust fund is. And it would be able to spell out specific things like it pays for education. That way my father is assured that with the wealth he's accumulated, all his beneficiary, the person who gets the benefit at the end of it. So let me go, let me say here, when you come into our offices and we're trying to devise, do you want a will, do you want a trust, is it a POA scenario, is it a nomination scenario? We want to understand your vision, we want to understand, do you want to preserve your wealth, to grow it, to control it, to protect it? Do you want to protect it for vulnerable beneficiaries? Like he mentioned, there was a child. You know, one thing people don't know is that guardianship can actually be bequeathed. God forbid, if I was dying, I can actually bequeath guardianship of my children to my sister, so that my husband is obligated to raise them with my sister. So that's not things that people know, but guardianship can be placed in your will as you can bequeath that. So, and then build or consider now that this is in terms of the vision. And then also we ask you very clearly, and you have to know we're bound by confidentiality, about your apprehensions. Sometimes you want to lock out errant beneficiaries. Errant because you know a certain child, you can see the way he's going, that he's going to try and do certain things. Or sometimes it's that they have a child out of wedlock and the law allows you. There's no obligation on a parent, let me just say this, for any child to inherit from them. There's none. Children these days, with Gen Z and millennials, seem to think that they are entitled, but you can decide to give all your money to cats, yeah? Then mitigate foreseeable liabilities, and then it can also help you to avoid lengthy public processes. I don't want to go without telling you about this so that I can entice you to read about trust. So this is what we call a typical trust structure. If we establish for you a trust, usually the trust is at the top. We usually incorporate a PTC here. This is for legal asset protection reasons. And then this is now all the money you have. So one over there is your doctor's practice. Maybe you have other businesses, this and endowment assets. If I had time, I'd have explained how that works, but I won't today. Let me show you something else that's going to make you happy. Yeah. So once you've incorporated the trust, incorporated is just like a company. You know how you create a company. Once you've created the trust, we settle the assets. Settling now, in trust, we don't use the word transfer, we use the word settle. So we settle the assets. We move the assets from your name to the name of the trust. So why is that important? Because number one, settlement of assets into a family trust is both stamp duty exempt and capital gains exempt. What does that mean in reality? If today, Dr. Ongweno, his son got married and he said, I'm giving you a house, despite the fact that he's giving his son a house for love and consideration, like his son is not paying him any money, he'd have to pay, if the house is within a municipality, 4% duty, and it's 15% now, 15% capital gain tax on the gain made, yeah? But if he used a family trust, if he incorporated a trust for his son, Ongweno family trust, he would move it free of duty, free of whatever, and his son would own it like that. Now, here's the next level. Why a trust is important. If his wife's son, I'm not cussing him, decided to leave him 5 years into the marriage, she cannot come to make a claim for this house as matrimonial property, despite it being their matrimonial home. Why? The son does not own it. It's owned by the trust. And who are the beneficiaries of the trust? The son and his bloodline descendants. So his children would have an interest in this asset, but this woman cannot just come and decide, now, I have married you for your money. You've seen I think I can quote this because it's in the media, you've seen Philip Moy saying, don't look at me as Moy's son. Because, yeah, it's not his money, it's the Moy Trust money, and there's nothing you can do about it. So it's both a legal, a good way, efficient way of holding your assets, and a tax-efficient way of holding your assets. So in terms of tax benefits, trusts have a lot of tax incentives and benefits. So also the income of the principal sum of a registered trust is tax-exempt. What does that mean? Currently, if you own your doctor's practice as a company, at the end of the year, you're paying CIT, corporation income tax, at the rate of about 30%, yeah? That's what you're paying. And if you've registered this as a sole proprietorship, you're still paying at a similar rate, maybe now about 33% because of the pay brackets are higher for the higher you go. So what about for a trust? As long as this money is coming from your practice and coming to the trust, it will not be taxed. The principal or income of the trust is tax exempt. It sits there in the trust and allows you to do whatever you want for the beneficiaries without being taxed income tax. So another thing is, okay, I'm just stopping now. So another thing, and this one is maybe one of my favorites, and the reason why hata mimi naulizanga Kenya unahama uende wapi. In this country of ours called Kenya, I've met Dr. Ondieki today. Dr. Ondieki creates a trust for her children. I've never seen her, I don't know her. I can come and settle this building into the trust for her. She's the CEO of Nairobi Hospital, and I've gotten the biggest stand out of Nairobi Hospital. I can settle this building or a house or anything into her trust. Yeah, it's good, but it's also, as you can see for yourself, a way of doing business without being caught. Yeah. So anyway, that's nice. So what does that also mean? That if you have a debtor who owes you 10 million and you don't want to pay income tax on it by declaring it, yeah, they just settle it into the trust and then the 10 million gets into the system without being taxed. Yeah, so the other thing that I want to, also tax exempt outgoings. Now this one is nice. It's the Finance Act 2023 is proposing to scrap this, but don't worry, because they proposed to scrap it again in 2022, but it failed, so we think it's going to fail again because the people who are benefiting from it are the same people who are being asked to scrap it. So any money, I've explained to you now how we've put this building or other things into the Dr. Ondieki Family Trust. Any money that leaves the trust up to 10 million per beneficiary per financial year is income tax exempt. What does that mean? If my dad gives me 10 million today, I have to declare it on 30th June, and then it will be deemed income, it will be deemed income, and then I have to pay income tax on it based on payee brackets. But now, if my dad gives it to me from a trust, I will not have to. That means if we have 5 children and he's named 5 beneficiaries, my dad can distribute up to 50 million income tax. If we are 10, or if he's also named his brother and my mother and other people, all that money can be distributed free of taxing. Yeah? And then the final one is that any money used exclusively for adult housing, medical, and adult housing, medical and education, also income tax exempt. Maybe this is important for you in terms of the medical part. Your patients, if they structured their wealth better, they'd be able to make a lot of payments for medical with incurring nominal tax issues. So all of that information is here. If you want this package, I left some outside, so they'll give them to you. And you're also free to just text me, to email me and tell me. So the final thing I want to say is the advantages. Number one is tax planning. I've already shown you about that. Asset protection. I've shown you how it protects your assets from matrimonial claims. It also protects your assets from insolvency claims, because if now Dr. Moledina's practice, all his wealth, his family home, everything was held in the trust, and God forbid there was a claim against him in his personal name, those things cannot be attached. So it's protected from matrimonial property claims, and the Matrimonial Property Act specifically states that assets held in trust are not matrimonial property. So there's no, we're not going to court to dispute that. That's section 6 of the MPA. All of them. None of them can make a claim. You just have to decide which one you use as a beneficiary. So also, in terms of asset protection, what it does, your beneficiaries cannot now, your son, if you have a son who likes to go incurring debts, he cannot go and incur debt and then they come to attach his house, or they come to attach an asset you've placed, his car that you've bought for him, and it's in the trust. So that's how it affords asset protection. And then, of course, it avoids probate. You know probate is nasty. We get to see everything you earned, and it's a public process. So flexibility, I've explained for you that now trusts are not just a succession issue, it's a wealth management issue. You can use a living trust to manage your wealth when you're alive, and it will transition to after your death. Then, because of Jenga Karume, we've adopted something called an enforcer. In other jurisdictions in the UK, it's called a protector. So our law was amended in 2021 to provide for an enforcer. In the past, I've told you, we saw trustees act badly because they were like the overall, they were the final person. But now, you can appoint an enforcer. So in your lifetime, of course, you're a trustee. But after you're gone, now, like in the case of Jenga Karume, if the beneficiaries had the right to appoint this enforcer to come and oversee the trustees, they'd have avoided the issues we have. So now that has come up. So that's it for now. I am available for questions. Thank you.
Diana, you have done a wonderful job. I'm sure now that they are not saying end of life, they are saying starting of life. Now I would request all the speakers, starting from Grace, ESCO Pharmaceuticals, Dr. Gueno, Sister Rachel, Dr. Asaf, and Diana to come in front. I'm sure there will be more questions for Diana than anybody else.
In fact, this first question comes from me as I go to sit. Thank you. I waited for this session. I think all the sessions were good, but I think this is a session I can.
You are on the question table. Give the mic back.
Yes, sir. Can I make the first question?
Okay.
I know we'll get questions, but I just wanted to make a question to Diana. Excellent presentation. In fact, when we are there, you are part of the people who have joined the, you gave me as an example, but I've joined the bad wagon. So I'm going to take a trust. Now, one question I want just to, well, we'll still talk. Now, when you put a trust, family trust, it follows the genes. You know, now we go down to the genes and family. I want to go very close. Now it goes to the genes from you to the other genes. Now, is there issues of what kind of children? Is there genetic linkage? Because there's a reason I'm asking. I know that we have children out of wedlock. But I'm just asking, if somebody comes and dispute, you say you have a trust, there are 5 children. Somebody else comes and say, oh, I'm also another child. What happens? That's question number 1. Probably, before I do the other question, maybe if she'll want to respond, she'll respond. But the other question might.
Okay, so first of all, with a trust you choose, as I said, there's no legal obligation to give anyone your assets. So even with a trust you choose, you can choose to say bloodline descendants. We do have a scenario, I do have a client where they have said because the father has a child of you spell it out as whatever you want. So you can say bloodline, like between my husband and I, if I know my husband has a child out of wedlock, I can say bloodline descendants of Diana. That means the people who have Diana's blood are the ones who get it. Now that's just subject to agreement between me and my husband. As I've explained to you, I have another trust where now the man has a child out of wedlock, so we have said bloodline descendants of his daughters. He has 2 daughters, so we are using the daughters as the ones. And now, unlike wills, where if a dependent was left out of a will, a dependent is someone who is immediately before this person dies depending on him. If it was left out, such dependent has a right to go to court and ask for a provision under section 26 and 29. But with a trust, no such right exists. Yes. So they cannot come to vary the trust just because you are locked out. Yeah.
Thank you very much. Let's open the floor for discussion because, you know, there are so many questions and we have only 7 minutes.
Okay.
And then we are closing
I was
up.
going to ask also of bloodline because, you know, as Africans, we have a lot of, there can be bloodlines going forward and bloodlines going behind. So how about the bloodlines going behind? Okay, Caro.
Diana, thank you. Dr. Kinyanjui, Rachel, Buri, Grace. I thoroughly enjoyed this session. First of all, because it was very
lively,
practical. Yeah. So to Diana, to avoid legal probate, how come banks in Kenya don't have this form that we can fill payable on death? Because then I lost my parents, and to get what little they have in the account is so difficult. You know, you have to wait for 6 months and letters of administration, then grant letters, and this payable on death form, is it available in our local setting? That's the first comment. The second one is, like for me in my office, how long after I go, are the records in my office, do they belong to the clients or do they belong to the next person who takes over? Thank you so much.
Diana. Give to Diana.
Thank you to all the awesome presenters. And thank you for the opportunity to give a little bit of feedback and to ask a couple of questions. And definitely my question is going to Diana. Dr. Ogweno and myself, we are both fertility specialists. So we have opportunity to help couples who are having trouble getting children. And one of the problems that we find is that whether it's a man or a woman, they have trouble, the man can have trouble producing viable seed to get genetic children, and the woman may have run out of eggs, or the eggs may be of poor quality, and therefore not capable of offering her the opportunity to have her own genetic children. So if we were to get up and say that you're putting a restriction to only direct bloodline descendants, how does that handle children who are born into the family as a result of sperm donation or ovum donation? And what happens to the children of any other bloodline descendants should such treatments be necessary for them? Thank you.
Thank you. Thank you. That's an excellent question. Let me start with your question. So that was just so in terms of that, the records, they would now belong to whoever is that the legal nani that follows. The second one, the other question, legal probate. Do we have a payable on death form? So I've seen the WhatsApp on the Twitter and the thing going around on WhatsApp saying that we do, but I have not come across it. I'm waiting for banks. We also sent some letters. I asked someone who's at the bank. Nobody has seen it, but I'll tell you what our law of succession says. Our law of succession says that once you die, all your assets vest in the High Court. So I don't even think such POD would still have authority outside the Law of Succession Act. I don't think it's there, that's first thing. But number two, it's that in our Law of Succession Act, it requires that any assets that are held in a deceased name, which is why in the trust they're not subject to the probate because they're not held in the deceased name, go through probate, whether it's under will or it's under intestacy if you didn't have a will, and then after that they would be devolved accordingly. So in Kenya, I don't think it's applicable, and I think it's for good reason, is because there's been a lot of fraud, like our background, as in you see a lot of things, even with pension benefits, which are excluded, you can see the drama we are seeing. With WIBA benefits, you can see the drama we are seeing with insurance benefits. So I guess that was the thinking of the lawmakers then. So I've answered the question on bloodline that Dr. Ongweno had asked. Yeah, I think, so the issues of children with genetic linkage, yeah, I think we are dealt with that. As I've said is, a beneficiary will be defined on the terms that you decide. Yeah.
Thank you, ladies and gentlemen. You can see all the questions are directed to Diana. I thank all the speakers, and there is no time to ask any. Oh, okay, fine. Judy?
Yeah. Thank you, every presenter. Those were very good presentation. My question goes to Dr. Asap. I hope I got your name correct. This is on advanced directives. I have worked in a medical ward where you'd have, and these were usually mothers who would do the advanced directives, and they would include their sons or their husbands to be able to make the final decision and find the forms. However, you get children coming to challenge, either if they did with the mother, the mother did with the father, the son will come to challenge that advanced directive, or one of the sons feels they were not included. So these questions are both going to you and Diana. So how do you manage to bring the family together to do the advanced directive? And what is the legal position in terms of a son challenging an advanced directive done by a parent, either with the father or with the other, with their sibling?
Yeah, thank you for that question. So the best practice is when you know your patient is, and actually not every, even ourselves, we need to start thinking if we get into a capacity where we're not able to make decisions regarding our health and even regarding our wealth, who do we hand over that responsibility to? And that's one of the conversations when the patient comes into palliative care setting we'll start with. And then, as I mentioned, is that you have to have, as much as possible, encourage this decision to be done in a family setup or a family conference, so that you end up reducing a lot of conflicts within the family. And then once you do that, also make sure you document. So you'd say we had this family conference, so-and-so were present, and this is a decision that was reached. And this is decision based on the patient and not from the family member. So it's the patient making decision and saying, I'm making these advanced directives and giving this power of attorney to so-and-so. In instances where we have had, for our case, I think we are lucky with mild dispute. We're able to go back to the family setting and have a family conference and try to iron out those differences. But I know in some facilities where there have been huge disputes where sometimes one family member says, I want to give the best care to my parents and I want to make sure they go to ICU. While in another case, the person with the power of attorney says, no, that's not what our parents wanted. This is not the decision of the family. And that brings a lot of issues. And for us, it's documented. Then most of the time, you find we're able to sort of align with the person who has been given the power of the mandate to execute or to give directions in terms of the care for this patient. But for minors, I know sometimes even we have to seek even legal direction from the court so that they can guide us on the way forward. But I'm sure Diana will add more.
Yeah, so let me mention that it's twofold, as he said, the legal and the social bit. Even us, when we're just managing an estate, we like to manage expectations. That's the social part. Get these beneficiaries involved, get these people involved so to manage expectations. Because many times these disputes arise from people who have different expectations and then they're saying things going this way. So I think doctors are in a good position to do that. Like in my case, when my father was dying, our doctor did that. He also died of cancer. She brought us together, and she told us all of those things. And of course, we reached a point where I said, okay, fine, take the directions from our brother. So I think that's the social part, the psychosocial, the social part. But now from the legal perspective, as he said, you have to ensure that if you are purporting to issue such documents from your office, they're drawn to the specific legal specifications, yeah? Like they meet the legal threshold. In this case, what you're asking about is someone is giving authority. You see, my authority to make the medical decisions about my life is with me. About my daughter is with me because she's under 18 and it's mine. So now if I'm choosing to delegate that authority to a third party, legally how do I do it? I do it through what is called a POA. It's a power of attorney. You guys can call it an advance directive or it can take whichever form, but the nature of it at the end of the day is a power of attorney. So in that case, it's a specific power of attorney. Make sure it's drawn to the right specifications. It is witnessed as should be. If it needs to be registered, it has been duly registered. Yeah. So that is just the short and long of it. As I had mentioned, we usually give this, I can send you precedents for that, that can be used like a template that can be used for that, because they may take different names and shapes and whatever you want to call them, but at the end of the day, that's a POA. For the other ones, like a do not resuscitate, there is also now the legal whatevers that we meet for that.
Thank you, ladies and gentlemen. We are closing the session. Whatever the questions are, you can meet her and you can meet other speakers. Time is not on our side. Yes. And do you agree that I chose a good lawyer firm to address it? Please give them an applause.
Thank you.
And register yourself, 50% discount, funeral expenses paid.
As we finish, quick one, Moledina. I agree with Dr. Kinyanjui. I think they've handled the sessions quite well. And I just want to throw the spanner in the works also. Coming to Dr. Paul Koigi's comment, which is very crucial. Now, when it comes to reproduction, there are issues of donor, there are issues of third parties. I think consent is very, very important. Consent is what carries the day. Even when you talk about surrogacy issue, the consent will carry the day. Well, Dana has said, when it comes to issues of law, then you can choose. And then the last thing I got from Dr. Kinyanjui here is, they call it happy death? Yes, and I agree with that. But I said, I know we've been looking at oncofertility, in other words, treatment beyond cancer. But there's also an area of posthumous reproduction. Yeah, which I'm sure if we had a lot of time, probably he will throw in something, and how it will go up. That's how you will have a happy death. So we'll have to do research on posthumous reproduction. But thank you very much.
Okay, thank you very much. And now I will invite Dr. Ogweno to give the closing remarks and the gifts to be presented to the speakers. Yes. I would request Dr. Odula, can you do this
Yes,
Thanksgiving work?
We'll do the gifts. Thank you very much, everybody.
To all the speakers. Yes. Please come forward and take your gift and open it at home, please.
Thank you for sponsoring, for physically being here the whole day, and we really enjoyed your presentation. Such an honor to be here.
It's a very nice Yeah, give one to Ken, one to Sylvia. Sylvia is here. Ken Bodo.